workshops, oral and poster competitions, as well as quiz competitions, in which students of not only RMU, but different universities all over the country have shown enthusiastic response and have become a worth mentioning part. Not only this, we have invited international speakers of different specialities to brief us over their respective fields and enlighten us about the pearls of knowledge they hold. Surgicon 23 is one of its kind, where students themselves have come up the idea of providing a platform to inculcate knowledge of different specialties of surgery, that too with a beautiful amalgam of surgical researches being presented by the students. Now I'll start with the humble introduction of first esteemed speaker of the day, Dr. Farhan Nadeem, MD, a graduate of our very own university, Rawalpindi Medical University. He has a residency of Brockdale University, Brooklyn, New York. He also has fellowship in Temple University Hospital, Philadelphia. He is currently a cardiothoracic surgeon at UHS Wilson Medical Center, Binghamton, New York. He's a diplomat at American Board of Surgery, as well as a diplomat at American Board of Thoracic Surgery. Thank you so much for joining, sir. Over to you.
Thank you, Aisha. It's a pleasure to be here and talking to you guys. I'll be talking about the state of the art in cardiothoracic surgery, what's new, and what are some myths, and we will try to go over them and address them one by one. And then we will talk about what is upcoming in the field. At the end, probably last like 15 minutes or so, we can answer some questions, all right? So let's see. Okay. Can you see my slides?
Yes, sir.
Okay. So as I said, my goals are to clarify the misconceptions and exemplify the evolution of cardiothoracic surgery. I will also indicate what is new and what is exciting about my specialty. My goal is that ultimately at the end of this talk, there will be a few people who will reach out to me and be like, okay, you know what? I want to do cardiothoracic surgery. So myth number one, probably you guys have heard it a lot about coronary artery stenting and how it is better than coronary artery bypass grafting. Stenting probably started probably in like 1990s, late 1990s, I would say. Before that, patients who would even present with ST elevation MIs would end up getting CABGs. So you can imagine, the wait time for those patients was tremendous. Cardiac surgery initially started in like 1960s or so, with CABG coming into existence in like probably more so in like late 1960s to early 1970s. And since then, CABG has been saving lives. In terms of those patients in late 1990s who were getting CABGs done, obviously they were waiting quite a while for them to get an intervention and to get revascularized. So stenting was a tremendous opportunity and saved many lives. However, having said that, patients who had significant coronary artery disease and the presentation was not STEMI, in those patients, the role of coronary artery bypass grafting or CABG still sustains, and I will tell you why. So going to left main disease and presentation with stable angina, unstable angina, or STEMI, taking STEMI out of the picture, in those patients, CABG so far has been way superior as compared to PCI. In terms of all-cause mortality, there's this meta-analysis from last year, actually. They looked at 5 randomized controlled trials with a lump sum of about like 4,500 patients, and they looked at the outcomes. And what they found was that the all-cause mortality at 30 days favored PCI, understandably so, because cardiac surgery or any type of cardiac surgery comes with an inherent risk of mortality from things that can go wrong. And then looking at MACE, or what we call the composite outcome, including myocardial infarction, stroke, and death, in the CABG arm and in the PCI arm, it favored CABG at the 5-year mark. And as you can see, Sorry, 1 second. Let me try to get out of here. Here we go. Okay. So yeah, as you can see, the odds ratio goes up to as far as 1.89 favoring cabbage. So multiple trials have shown that over the years, and I would just bring your attention to the primary outcome line where PCI is compared with cabbages at 5 years. There was Syntax trial that showed that the primary outcome, which was death actually, was 31% in the cabbage arm compared to 36% in PCI arm. Actually, it was primary outcome also included myocardial infarction, and death was 31% at versus 36% for PCI. Then the pre-combat trial also 14% versus 17%, Noble trial 28% versus 19%, Nextel trial 22% versus 19%. So by far, this is like out of question that cabbage has better survival when you talk about cabbage versus PCI at 5 years. Though the inherent risk of the surgery itself brings down the numbers for the first 30 days. Another slide showing the same thing, that up to 13 years, cabbage had better survival compared to PCI. And I would like to bring your attention to the 2-year mark, and you can see that at 2 years, the lines are pretty close, and after 2 years, they start to spread apart. There are multiple trials that have shown that actually the crossover happens at around the 2-year mark. Now going to cabbage for 3 vessel disease. FAME-3 trial came out the year prior to last year, and what they did was, this was a multi-center international non-inferiority trial. They enrolled 1,500 patients. Inclusion criteria was 3 vessel coronary artery disease with greater than 50% stenosis and not involving the left main, and which was amenable to revascularization. That means that the blood vessels were big enough that they could receive a cabbage. And what they compared it to was FFR-guided PCI. For you guys, FFR-guided PCI means that you insert a catheter into the coronary artery itself, and you measure what is the differential of flow from the proximal artery to the distal artery after the stenosis. And that will tell you how significant your stenosis are. If your stenosis is significant enough, only then you will get a stent placed. And they compared it to the same, but instead of putting a stent in, they did cabbage. And what they found was that death from any cause, myocardial infarction and stroke, or repeat revascularization was significantly different between the two. It was 10.6% for PCI, and it was 6.9% for cabbage. Obviously, this study was not powered enough to show a significant difference. And then going to subgroup analysis, what they found was death was 1.6% versus 0.9%, and MI was 5.2 versus 3.5%, and stroke was 0.9 versus 1.1%. Then they concluded that because of the low power, that at least PCI and cabbage, FFR-guided PCI and versus cabbage, the FFR-guided PCI is not non-inferior, which has double negatives, which basically means that it is inferior with respect to incidence of death, MI, stroke, or repeat revascularization. However, all of these trials, they looked at coronary artery bypass grafting, looking only at using one mammary artery or internal thoracic artery, as the British nomenclature calls it, and rest of the bypasses were veins. What that means is that if somebody's getting a cabbage ×3 or a triple bypass, they would have one left internal mammary artery, and the rest of the 3 grafts would be veins. They did not include any total arterial revascularization in which the bypasses are done using internal mammary arteries from both sides, or using radial arteries or gastroepithelial arteries. These are a few configurations that you can use when you're doing using all arteries. As you can see, you can use lima and rima, or lita or rita, as you call it, and also the radial artery, and arrange them in a way to bypass your three coronary arteries. One thing of note for you guys is that multiple studies have shown that the arteries, they tend to last longer compared to veins. In a study, it was found that about 10 to 20% of the veins, they tend to clot off after after coronary artery bypass grafting within first 30 days after the bypass is performed. So, you can imagine the importance of the internal mammary arteries. One of the reasons that the left internal mammary artery does not clot off is because it produces its own nitrous oxide, which keeps it patent. All right. Now, this is an interesting study showing the same, making the same point, comparing multi-arterial grafting versus a single arterial grafting at 12 years. And you can see the significant survival difference between the multi-arterial arm and the single arterial arm. So going back to the same point, CABG remains the gold standard for coronary artery revascularization, no matter what the cardiologists tell you, etc., especially for stable angina patients. So far, no study has shown superiority of PCI or stenting for stable angina compared to CABG. However, you'll be surprised as you go into practice that how often patients get stents for no reason, actually. Myth number 2, TAVR has replaced surgical aortic valve. This is an upcoming topic, actually, and there have been multiple trials. The first TAVR valve was implanted in late 2010s or so, and since then it has been in actually early 2010s or so, and since then it has been fairly taking most of the market share. So looking at all the trials that have been done comparing TAVR and SAVR head-to-head, starting off with the Partner 1A trial. So this was for high-risk patients with severe aortic stenosis who had expected mortality of greater than 8% if they underwent if they underwent a surgical aortic valve, and this 8% mortality was within the first 30 days. And what they found was that the patients who underwent surgical valve had a 62% chance of dying at 5 years versus 67% if they got a TAVR valve done. However, keeping that in mind, most of these patients were so sick that they would not have been, as you can imagine, the 60% mortality at 30 days is at 5 years is quite significant. So they're quite sick. So for those patients, considering that they're very high risk and they have other medical problems, TAVR initially was thought to be a great idea, and it was, and it worked out quite well for those patients. Then simultaneously, more and more studies were done, and Partner 2A trial compared patients with the moderate risk, which was 4 to 8% 30-day mortality risk, and it looked at TAVR versus SAVR, and it found that there's no difference between TAVR and SAVR. Followed by the Partner 3 trial, which is a low-risk trial, and it looks at patients who had less than 4% chance of dying because of getting a surgical aortic valve replacement done. And what this study found was that at 2 years, there is no difference. However, the final data from this study is still pending. Having said that, though, one of the main things to know about surgical valve and the TAVR valve is that both are bioprosthetic valves. What that means is that the leaflets are either porcine or bovine, so they tend to degenerate with time. And we know that patients who are younger, who are less than 60 years of age, the chances of those leaflets getting calcified is much higher. So they would have stenosis. If they're 60, they would have most likely stenosis at 10 to 15 years of age. That would require them to get another valve done. This is circumvented by putting a mechanical valve in these patients early on when they're, especially patients who are less than 65 years of age and have favorable risk profile. Then we go ahead and put a mechanical valve in them, and the mechanical valve lasts for life. However, the downside with mechanical valve is that they will be requiring anticoagulation for the rest of their life. So by far, in terms of needing a subsequent surgery wise, mechanical valve has not been superseded by anything other than the Ross procedure, which is discussion for another day, but involves putting the native pulmonic valve in the aortic position and putting a homograph pulmonic valve. We can talk about it later, or somebody can ask me about it, and I can go over what it means to that. So, okay, so moving on. So as I said, patients who are younger, low risk, intermediate risk, and patients who are high risk, that's how we think about aortic valves, aortic stenosis, and patients who have simultaneous like coronary artery disease, who need CABG AVR. In those patients, the threshold is a little bit lower to do a surgical approach versus doing a percutaneous approach involving a TAVR valve and PCI. In patients who are 65 or younger, less risk patients, as I said, they most likely will end up getting a surgical valve and getting a CABG if they have significant coronary artery disease. However, patients who have one or two vessel disease or are much older, they most likely will end up getting or have a higher risk profile. They will most likely end up getting a TAVR valve with PCI. Now, this is a very interesting slide. It tells you about how decisions are made for patients in this day and age who are much younger. So looking at patients who are 45 years to 55 years of age, it's kind of hard to decide which valve to put in. Now, if it's a female, you cannot put a mechanical valve in because they cannot get Coumadin, especially in the years when they can get pregnant. So in those patients, just because Coumadin is teratogenic. So in those patients, you have a lower threshold of putting a bioprosthetic valve in. Other option is to tell them to, not get pregnant. In those patients, Ross procedure is a very good alternative. Ross procedure is you take the patient's own pulmonic valve, you take it out and you put it in the aortic position after resecting the patient's own aortic valve. And then the space that you have where the pulmonic valve was, you place a cadaveric pulmonic valve there. Obviously, this is a bigger procedure, much higher risk procedure. You have to reimplant the coronary buttons in those patients. And despite the difficulty and everything, the durability of this procedure far exceeds the mechanical valve and the bioprosthetic valves. But again, not everybody qualifies for this procedure as it's high risk and it's only for younger patients. Going to SAVR valves, patients who have a life expectancy about 25 to 30 years or so, or 30 years or so, and are currently, probably it doesn't matter for these patients. They end up getting like a mechanical valve, especially if they are males. Patients who have life expectancy of about 20 to 25 years or so, and are currently like in 50s or so, then you have to have a serious discussion with the patients that should we do a surgical valve first, and when the surgical valve gets stenosed, then put a TAVR valve in those patients, or should we do a TAVR valve first, and then once this valve gets stenosed, put another TAVR valve in those patients. The problem usually comes in the third time, because now after like 5 or 10 years of the structural valve degeneration that they would have gotten, taking out the TAVR valve and planting a SAVR valve is a much higher risk procedure. and you really want to avoid that. So, so just a food for thought for you guys that in patients who are younger, they're better off getting either a Ross procedure or a mechanical valve. If for some reason they cannot get a mechanical valve, then getting a surgical valve first and then thinking about TAVR and then probably another TAVR down the line is a good option. So this is sort of like a nomogram that tells us like which way to go. And over here in the US, most of the discussion, most of the decision making is done by the patient and the surgeon and the cardiologist together. And we tell them that if that what is their risk profile. We tell them that if they get a mechanical valve, what can happen down the line. If we get the surgical bioprosthetic, what is going to happen down the line. And if they get a percutaneous bioprosthetic, that is a TAVR valve, then what is going to happen down the line. And after that information, an informed decision is made by them usually. So going back to the same point, TAVR is just another tool in a surgeon's toolbox for aortic valve replacement. And this concept that that surgical valves are going away and would be gone soon is not correct. Number 3, cardiac surgery is painful and patients stay in hospital forever. I have heard this a lot, actually, that that cardiac surgery is that the patients don't get back to their quality of life after getting cardiac surgery. This is not correct at all. Actually, a sternotomy hurts much less than a thoracotomy incision, and this has been proven time and time again. Using these ERAS protocols or enhanced recovery after cardiac surgery protocols, it has been seen that the duration that the patients stay in the hospital has significantly decreased. What I see with my patients after sternotomy, they usually stay in the hospital for about 4 to 5 days, and they get to go home. And that's for like most of the patients. Patients who end up getting like minimally invasive surgeries or so, like minimally invasive mitral valves, etc., they tend to go home a day or two earlier, if anything. However, in those patients, we usually do nerve ablations and all in the for the intercostal nerves using cryoablation techniques, and that is also a confounding factor, and they have less pain because of doing the cryoablation rather than the incision itself. But off the bat, the thoracotomy incision, regardless of the size, usually hurts way more than a sternotomy incision. Some of the things that we have incorporated in our practice for patients who are getting cardiac surgery is that we preoperatively give them Tylenol and gabapentin. We do carbohydrate loading and protein supplementation. The carbohydrate loading is done 2 hours prior to the surgery, and then they go to the operating room. In the operating room, the anesthesia team is very good at giving them Precedex or dexmedetomidine, lower dose of fentanyl, and we inject liposomal bupivacaine in the site of incision, which lasts for about they market it as 7 days, but actually it lasts more like it's more or less like 72 days or so for those patients. Every patient gets antibiotics. Fluid resuscitation is very judicious. We are very aggressive about glycemic control. We don't let their sugars go above 160, and we are very careful about transfusing them after the heart surgeries, because we know that they tend to stay longer in the hospital if they get transfused. And there are some studies showing that their survival is worse if they require transfusions for any type of heart surgery. Post-operatively, these patients get multimodal analgesia. They get gabapentin, they get Tylenol, or and then they also get lidocaine patches. They get oral opioids, usually oxycodone and the PCA. Just they have the button to use to inject fentanyl. We mobilize them either the same night after heart surgery, or we mobilize them early morning the next day. Everybody gets a Swan-Ganz catheter in the neck, and we, as I said before, we are very anal about the glycemic control. Going back to the same point, by following a stringent egress protocol, patients stay in the hospital has been significantly decreased with simultaneous improvements in pain control, and they stay in the hospital for about 4 to 5 days on average. Mitral valve repair is complex and risky surgery. I have heard this a lot as well, that the mitral valve repairs are only for high volume centers, etc. This is not true. This is very safe procedure, very much reproducible. There are multiple techniques to repair the mitral valve. With the advent of robotic cardiac surgery, it has been sort of like a saving grace for robotics in the field of cardiac surgery. Mitral valve repair has helped do that. So what we do is we basically, depending upon what is going on with the valve, we analyze the valve first. Everybody gets an annuloplasty ring, as you can see in the picture. If it's P2 or if it's a posteriorly fled prolapse, then that area usually gets resected, or plus minus they get a new cord in place. If it's the anteriorly fled, which is prolapsing, then it usually ends up getting a neocord versus resection. If there is a defect in between in the leaflet, we patch it with pericardium. And then we place an annuloplasty band. This can be done with a robotic approach, this can be done with a thoracotomy approach, and this can also be done with the standard sternotomy approach, which has been happening for the last 30 years or so, maybe 40 years. As you can see, the mortality risk after mitral valve repair is very, very low. It's less than 0.3% in low-risk patients. It's 0.3 to 0.6% in moderate risk, and about 1% in highest risk patients. So it's very much reproducible, reliable, and exceedingly safe. And that is one of the reasons that patients who have asymptomatic valve disease, we tend to operate on them, versus patients who have asymptomatic coronary artery disease, we do not tend to operate on them. And the same goes for aortic valve. Atrial fibrillation is a benign arrhythmia, and surgical ablation does not work. This is also a very common myth. I will tell you why atrial fibrillation is not a benign arrhythmia, in my opinion. 20% of all strokes happen due to AFib in a patient's lifetime. 5% per year is the stroke risk if they have AFib. If you give them anticoagulation, this risk goes down to anywhere between 1 to 2%, but it still stays there. In older patients, there is a higher risk of death if they have atrial fibrillation. And patients who receive concomitant AFib surgery, what that means is that when CABG or a valvular surgery is being done at the same time, if they get a Cox-Maze procedure, they have better 30-day survival, and this has been studied and proven by McCarthy, and that is in addition to the long-term survival benefit that they receive. Chemical success rate for atrial fibrillation is about 50%, and it lasts for long term, it lasts only about 30%. Pulmonary vein isolation techniques are effective in 70 to 80% of the patients for paroxysmal AFib. What that means is that you do cryoablation or RFA or radiofrequency ablation of the bilateral pulmonic veins while you're doing your cardiac surgery. And what that does is that, because most of the nidus for atrial fibrillation in patients with paroxysmal atrial fibrillation comes from just beyond the, just distal to the pulmonic veins. Just by isolating them, you prevent that nidus to become a generator for subsequent atrial fibrillation. And this is effective in 70 to 80%. There is a risk of perimitral flutter if you just do PVIs. So that's why we strongly recommend doing Cox-Maze procedures on these patients. This is the lesion set for Cox-Maze. This is sort of a difficult diagram to understand, but you're looking at the heart from the back. The area in front is the left atrium. This is the roof of the left atrium. You create a lesion set that is isolating the four pulmonary veins. So you basically cryoablate the area around the pulmonary veins. You create your box on the left atrium, and you create your lesion sets towards the mitral valve. And then same goes in the right atrium, that you isolate the SVC and the IVC and the right radial appendage from the tricuspid valve. This way, there's only one pathway that remains, and that is the native pathway that the patient should have. And this prevents them from going into atrial fibrillation. And if they go into atrial fibrillation, they won't conduct. So the ventricular response would be different from the atrial response in these patients. So going back to the same point, atrial fibrillation is not benign. Cox-Maze has success rates that approach about 70%. Myth number 6. This is a new one, actually, that lobectomy is the curative surgery for early stage lung cancer. This was after the landmark 1995 Ginsburg study that shows that patients who had a sublobar resection had 20% recurrence versus 5% recurrence of their lung cancers at 5 years. This has recently been challenged, and this is a famous Japanese trial that was done last year. And what they did was they looked at less than 2 centimeters peripheral non-small cell lung cancers, and they randomized these patients into getting a lobectomy, that is removing one of the lobes, like right upper, right lower, right middle, left upper, left lower, or getting a segment done, that is like apical segmentectomy, anterior segmentectomy of the right upper lobe, etc., etc. So what they found was that 5-year survival actually was better in those patients who had a segment done versus patients who had a lobectomy done. They also noted that, understandably so, patients who had segmentectomy done, because less lung is resected, they had better FEV1. However, this was not translatable to better quality of life. And they did not find much of a difference in local recurrence. Then at the same time, another study was done at Weill Cornell by Al-Turki and his group, and what they found was that the disease-free survival between lobectomy and sublobar resection is not different. In this study, they did not just look at doing a segmentectomy, but they also looked at just doing a wedge resection with enough of a margin. And what they found was that there's a survival advantage. As well, if you do a sublobar resection versus just doing a lobar resection. So the standard of care has changed for patients who end up getting who have a stage T1A non-small cell lung cancer, and the pendulum has switched towards doing a sublobar resection in these patients. And the last myth, that there are too many cardiothoracic surgeons in the world, and this is a study that was published in JACC, I think last year or the year prior, and it shows that 6 billion people have no access to safe, timely, and affordable cardiac surgical care. And what they recommended was that the lapses lie in having insufficient heart team recognition, not having heart teams, which means that the interaction between the cardiologist and the cardiac surgeon is not there. There is not enough support staff. There's gender bias. There's lack of training programs, there is lack of continued access to medical education, and then obviously research and academic issues that are there. And what they recommended was having a team-based training approach, having interdisciplinary collaboration amongst the societies, having opportunities for mentorship and sponsorship, and then having some surgical simulation programs, online virtual training programs, and opportunities for international training as well. And also providing more opportunities to publish as needed. So of course not, there are not enough cardiothoracic surgeons in the world, and this is going to get worse as the time progresses. So what is new and upcoming about my specialty? Xenotransplantation. I'm sure most of you would have heard about this. This is from July of last year, doing a course into human cardiac xenotransplantation by Bartley Griffith and his group. So this was a 57-year-old male who was on VA ECMO and not a candidate for transplant or for VAD. And what they did was that they had a genetically modified pig. About 10 genes were modified in that pig, and they used that heart and basically put that heart into this human. They kept the patient on ECMO. Day 4, they removed the ECMO cannulas. Day 34, they did the first biopsy on that patient. They did see that there was some rejection that was happening, so they gave him some IVIG. This patient survived to day 60, and at day 60 also received a biopsy, and they found that the rejection that the type of rejection that this patient was having wasn't improving, and they withdrew life of support. Again, this is a newer opportunity, and we will see how it plays out. After this experiment, there have been 2 more xenotransplants that have been done at NYU in New York. Other exciting thing in this specialty is the LVADs and how it's being advanced. The patients who are not candidates for getting heart transplants, they end up getting LVADs. This basically acts to take blood from the LV and put that blood into the aortic valve, beyond the aortic valve into the aorta. And previously we had the axial flow pumps. Those had certain problems like higher risk of GI bleeds, higher risk of pump clotting, so they required more anticoagulation, and high risk of hemolysis. This has been changed with the centrifugal flow pumps, which are basically magnetically levitated. And these pumps have better profile, less hemolysis, smaller pumps, and patients also tend to do better. And they tend to, the survival is actually quite comparable to transplant now at 10 years. This is just a video of how an LVAD works. Let me see if I can play it.
The HeartMate 3 heart pump is a left ventricular assist device, or LVAD, sometimes called a VAD for short. It helps your heart pump blood through your body. It has been surgically implanted just below the heart, where it is attached to your heart's left ventricle and to your ascending aorta, the main artery feeding blood to the entire body. The pump helps your heart by taking over the work of your left ventricle and pumping oxygen-rich blood to the body. The pump is made mostly of titanium. Electric motor inside the HeartMate 3 drives the pump, providing blood flow similar to a healthy heart. Although the HeartMate 3 LVAD is silent, it is normal to sometimes feel the pump working. To power the pump, a tube called the driveline passes from the LVAD through the skin in your abdomen. The driveline consists of 2 cables, the pump cable and the modular cable. One end of the pump cable is connected to the pump, the other end exits your body. The modular cable connects to the pump cable at the modular inline connector, and the other end connects to the system controller.
So just to give you an idea, of what's happening here.
Caution.
All right. So just to give you an idea of what's new in the specialty and what's going on, and where do we see our specialty going to um, in the next 5 to 10 years or so. Um, I think it's an exciting time to become a cardiothoracic surgeon. If you guys have any questions, I'm willing to answer. Can you guys hear me? Hello?
Assalamu alaikum, sir.
Yes, sir.
Yeah.
Thank you so much, sir, for such an enlightening session. The session has been great. There are a few questions in the chat box that need to be addressed. Sir, are these questions visible or should I read them for you?
Actually, I can see them now. Yeah. So the first one is, how do you see the future of cardiothoracic surgery with rapid development in interventional cardiology and the use of techniques like PCI? Excellent question. Hamza has asked this question. So Hamza, I mean, that was the first like two myths that I was talking about. Not much is going to change in the specialty of cardiothoracic surgery. It's just stents are just another tool. They're, the cardiologists are helping more and more people that way. And for patients who require urgent interventions, stents are good, like patients who come in with STEMI, but that is not the go-to approach for patients who require, who have a stable angina, and patients who have unstable angina, and patients who have STEMI. In those patients, if they have left main disease, have low EFs, have diabetes, have triple vessel coronary artery disease, and they're better served by getting CABG. And this has been studied over and over. In terms of TAVR versus SAVR, for low risk patients, the jury is still out there, so we don't know yet. The only data we have is for like, it's 2-year data. So that only time will tell, what happens with that. But for high risk patients, TAVR is better than SAVR, just because they're more likely to die by going to the operating room, and those were prohibitive risk patients. For moderate risk patients, if they're younger, then they will always be better served by doing a mechanical valve. The problem with TAVR valve is that you cannot put a mechanical valve using TAVR. So I don't think, SAVR or the surgical valve is going to go away in that regard. What can we expect from robotic cardiothoracic surgery in the future? Is it possible that cardiothoracic surgeons work may be replaced by robotic surgery? So, I mean, I do robotic thoracic surgery as well. So I do lung resection using the robot. I have not started a robotic cardiac program yet. But no, robot is, again, just another tool. The robot does not perform surgery on its own, right? Somebody has to be sitting on the console and they're controlling the robot. Basically, it's just laparoscopic instruments with greater degree of motion. What that means is that, like your hand, you can move it in multiple directions versus laparoscopic instruments that usually you can move in 2 or 3 directions or so. So that's why, and plus better vision with the robot and all this 3D vision, greatly magnified, etc., etc. So robot is already being employed in cardiothoracic surgery for coronary bypass surgery, considering the stakes are too high and it's a very fine anastomosis, etc. There are surgeons who are doing it, but it's only at very highly specialized centers. Mitral valve surgery is done at more and more places now. Aortic valve has not been robotic aortic valve surgery has not been been performed yet, just because that's a very high pressure system and problem is bleeding. I think there's only one surgeon right now in US who does them very selectively, but other than that, nobody's doing that. So yes, definitely there's a role for robotic cardiothoracic surgery. It is going to increase with time. Robotic thoracic surgery, I think, is getting more and more favor compared to robotic cardiac surgery. Robotic cardiac surgery, still people are doing it, but mitral valve aside, it's not mainstream yet. Has the development of diagnostic and image interpreting AI lead to decrease in the role of surgeons diagnosing cases and making surgical plans? I don't think that's going to change, because from day one, in any, even if when you're a general surgery resident, the first thing that you're told is that to look at your imaging by yourself. And I don't think it's going to go away, because your surgical planning relies on that. I don't know how would I trust um, a software to do the surgical planning for me. Sure, I can use that to filter out patients that do not need surgery. That's a totally different argument. But patients who do need surgery, and in those patients, I don't think from a planning perspective that AI is going to change much. Angiogram interpretation might be one thing that AI can contribute to in times to come for cardiac surgery patients. How do you see the field of cardiothoracic surgery evolving the next few years? Is a career as a cardiothoracic surgeon balance? I think the work-life balance is improving as time goes on in cardiothoracic surgery. One of the reasons is that that you're at a point that there are pulmonologists who are doing ablation stuff for lung nodules, and you do resections and lobectomies, etc. So your lifestyle is actually improving as a cardiothoracic surgeon, and so are your salaries, and so are your so you have less working hours, better salaries, and your work is more and more specialized, for lack of a better word. You are also taking care of much sicker patients than how cardiothoracic surgery patients were 10 years ago. Now, somebody has done something that has gone wrong, and now you're getting called and you are going ahead and taking care of it. Like patients who have AFib, cardiology was putting Watchman devices, and one of the Watchmen migrated. Now nobody would know what to do about it, except they would call a cardiothoracic surgeon who would come in, open the chest up, stop the heart, open up the aorta or the left atrium, take out the Watchman device, close it up, and let that patient go and save that patient's life. So your job has become more and more specialized, and you get called when most of the people don't know what to do. How hard is it to match into cardiothoracic surgery? How competitive is cardiothoracic surgery? Cardiothoracic surgery is getting more and more competitive as time goes on. Like if you ask me, like maybe 5-7 years ago, it was not competitive at all. The reason was that there were not many jobs in the US. As time goes on, there are more and more jobs, as the people who were like 60 to 70 years of age were still operating, and now they're retiring together, like all of a sudden. So there are tremendous jobs in cardiothoracic surgery. That means that everybody wants to do cardiothoracic surgery now, and there are not enough residency spots and fellowship spots. So for the last like 5 years or so, it has been tremendously difficult to get matched into cardiothoracic surgery. Before that, it was quite easy. What is the scope of cardiothoracic surgery in a low-income country like Pakistan? We have limited resources. Many times patients don't have enough money for procedures. That's a very good question. I mean, if you don't have resources in that situation, you improvise. And you would be surprised that there was Dr. Chima at KE, and somebody was telling me that for the mitral valve repairs, he used to make his own rings, make his own angioplasty rings, and he would use them to implant in patients. Each ring, if you import it from US or so, would cost you about a couple of $1,000, versus like you making them by yourself and sterilizing them won't cost anything, and the results are the same. So when you don't have resources, you improvise. For example, TAVR valve right now, putting a TAVR in US costs about $36,000. The device itself is $33,000. So it's tremendously expensive. And that's why third world countries, nobody can afford a TAVR valve, and they end up getting surgical valves. Surgical valve is about like anywhere between $3,000 to $5,000, and you can get a cheaper deal, if you go for an expired valve or whatever. They're really not expired, but in first world country, that's what they would say that the valves are expired, but really they can still be used. So those are much cheaper to use in Pakistan, and people that I'm in touch with, they're using them. So again, going back to the same point, if you don't have resources, then you improvise, and that's how you grow. In India, for example, they have started manufacturing their own TAVR valves. They have manufactured their own robotic system now. So, can you share any memorable patient stories or experiences that have had a significant impact on your career as a cardiologist? Tremendous stories. I mean, every single patient, teaches you something new. Like 3 days ago, there was this 21-year-old who had a car accident. He was on a bridge and the car went into the river, and he basically he drowned and had a cardiac arrest, and he was evacuated from the water. He was actually in PA, received CPR for 45 minutes because the water was cold. That sort of acted as to protect his brain, and he became hypothermic. So he was brought to the hospital with ROSC. They got him intubated, and they were not able to oxygenate him because he literally had water like up to his neck in his lungs. So he couldn't breathe at all. So I put him on VV ECMO, and he got decannulated from VV ECMO on third or fourth day. And he survived, and he's doing fine. And probably he'll be discharged maybe in a couple of days from the hospital. So yeah, there are like many patients like that. And it happens day in and a day out in my specialty. What are some common challenges or ethical considerations that cardiothoracic surgeons face in their daily practice? I think the most challenging thing is operating on patients when you see that, okay, they're like 85 years old, probably they don't have 10-year survival. Should you go ahead and operate on them versus not doing anything? Again, that has to be decided by the patient, not by you. But if you operate on those patients, then you're inculcating significant costs to the healthcare system. A cabbage costs about $50,000 per patient. And those are basically paid by either the government or the insurance company. So you have to think about that part, and that is, I think, that is very ethically challenging certain amount of times. Okay, what motivated you to pursue a career in cardiothoracic surgery? I had exposure after my residency. I had some exposure in cardiothoracic surgery. I was lucky to have good mentors. I rotated with them. I liked what they did, and I decided to do the same. And that's why I'm doing what I'm doing. How is the quality of life affected in patients with major invasive cardiothoracic surgery? Can patients live off of it? Absolutely, absolutely. So I also showed you a slide about it. Most of the patients get discharged from the hospital on day 4 or day 5. Once they get discharged, I tell them that for the first like 2-3 weeks or so, I don't let them lift anything heavy, just because the sternum is reapproximated by wires and plates, and it can break apart easily. After a month or so, they go back to their normal living. The other thing is, they come to us in complaining of chest pain, they tell us that, okay, I cannot walk a block. I start having this chest pain or so. If they have significant stable angina, and you tell them that, okay, you know what, I'm going to operate on you. There's 1 to 2% chance that you can die from the surgery. However, if the surgery goes well, this stable angina that you're having will not be a problem anymore. And the first time they come and see you, they usually won't even take the elevator. They would take the stairs and would come to your office. So it's very rewarding, and they have a very good quality of life after they get a heart surgery. How do you stay updated with the latest research and advancements in cardiothoracic surgery? And do you have any recommendations for reputable sources for journals to follow? I think as a medical student, it's a little bit early for you guys, but yes, JTCVS and is the probably the best journal out there for cardiothoracic surgery with the highest impact factor. Everything new comes to it, but it's expensive. You can use your library resources to get access to it. Otherwise, it's quite expensive to get access to. And the other ones are, there is CTS Net. It's a free website. It has the most latest information for everything that's happening in cardiothoracic surgery. How do you manage the emotional and psychological aspects of working with critically ill patients and their families in the cardiothoracic setting? That's a good question. I mean, the best way to deal with this situation is to be brutally honest. You tell the patients exactly what's going on. You tell their families exactly what's going on with the patient, and you tell them that how the things can play out, and you keep them updated. And honesty is the best policy, and it works out pretty well. How to join cardiothoracic surgery after MBBS? So after MBBS, there are two routes. One for US, I can tell you. For Pakistan, I'm exactly not sure. For US, after you do your MBBS, you do your general surgery training. That's one route, and then you do, which is 5 years of general surgery, and then you do 2 years of, or 2 or 3 years of cardiothoracic surgery training. If you do the other route, which is going to an integrated program, which is a 6-year program, then all you need to do is 6 years of cardiothoracic surgery training. In those 6 years, 3 years will be doing general surgery and 3 years will be doing cardiothoracic surgery. Those are more competitive spots. It's easier to get into a 5-year general surgery program and then going into cardiothoracic surgery than trying to get into an integrated program off the bat. What do you think are the most important skills and qualities for success in cardiac surgery? Like any other specialty, perseverance is one, grit is the other, certain level of resilience because it's a stressful job. The personalities in cardiothoracic surgery are very different. So you need to know how to handle those personalities. And yeah, hard work. That's the most important thing. And always think about the patients. Can females become successful cardiothoracic surgeons in Pakistan? Absolutely. Females can become as successful as men. There is no difference about that. The current president of AATS is a female. The president of American College of Surgeons 2 years ago was Valerie Rouge. I had the pleasure of working with her. She's also a female. My program director for my fellowship was also a female who trained me how to do thoracic surgery. She was a general thoracic surgeon. So yes, they can. And same goes for Pakistan. They can also become successful in Pakistan too. I mean, I don't think that those days of prejudice are there anymore. There is some, definitely there is some, but I think it's getting better. There are actually a few female cardiothoracic surgeons in Pakistan. There is one who trained in US and is in Pakistan right now. There's another one who's in RIC that I know of. So yes, there are female cardiothoracic surgeons. You just have to look at the right places.
Sorry to interrupt you, sir. We have short of time, so it's time to wrap up the session. I think most of the questions have been addressed. Thank you so much, sir, for sparing your time. It was truly an honor to have you today for such an informative session. Thank you all for joining. Our next session is a research workshop that will be held from 10 to 10:45. Till then, Allah Hafiz, everyone. Fi amanillah.
Thank you.
Thank you, Dr. Farhan, for that great talk. It was really interesting to see into the world of a cardiothoracic surgeon, and all of the people here who are interested in CT surgery did ask a lot of questions, and we are grateful once again for you to take out time and answer our questions. So we are honored that you could join us.
Of course, Hamza. Thank you for having me. If you guys have any questions, probably you have my email, etc. So reach out to me on LinkedIn, whatever. And I can do what I can. All right.
Sure, sir. Thank you so much, sir. Thank you.
Sure, no problem.
Okay. Moving forward, now we will be starting our first research workshop, second research workshop. So to begin, I would like to introduce our speaker, Mr. Jawad Basit. Mr. Jawad is the Senior Vice President of the Ravelian Students Research Society for this panel. He has 45 plus publications in his name and is a certified meta-analyst. He is a trainee editor at SJRMC and is serving as a peer reviewer for multiple international journals. He has taken his interest in stats and combined with his research expertise make him an ideal presenter for today's topic, which is a novel topic that many people at the undergraduate level usually don't try to pursue, as they find it to be a bit out of their range as an undergraduate student, and find this kind of research to be something that is very hard to do. So for all of our research enthusiasts today, Dr. Jawad will be presenting his session on the PICO table, the key to starting your first meta-analysis. So Jawad, if you could kindly open your mic and camera and share your screen to see if it's working, and then we'll begin the session.
Thank you, Hamza, for the intro. Am I audible enough to all of you?
Yes, you are. You are audible.
Okay. So thank you, Hamza, for the introduction. And I'm going to conduct a session on making of a PICO table. This is going to be a hands-on workshop. So we will be choosing a topic and making a PICO table while in this session. This session was supposed to last till 10:45. So I have divided it into two parts. The first part is theoretical explanation of different components of PICO. Population intervention, what they actually mean, and why do we combine them, and how to make a search strategy, what it actually is. It's just 4 or 5 slides, and then we will move on towards the hands-on part, and we will just be covering one database, that is PubMed, in this session. So I'll share my screen now so I can share my slides. Is my screen visible, Hamza?
Yes, it is.
Okay. So what is a systematic review? First of all, this is something that should have been given ample time, but the sake of this workshop is just to familiarize you guys with what actually a systematic review is, and then and to tell you the basics of systematic reviews and meta-analysis. So a systematic review is kind of a review article. There are a lot of review articles. There are literature reviews, narrative reviews, scoping reviews, systematic reviews, which can go into a meta-analysis sometimes. So one of those review articles is a systematic review. As the name indicates, it uses a systemized approach to collate all the empirical evidence that is pre-specified. Systematic review uses explicit methods to identify, select, appraise, and synthesize results from similar but separate studies in order to answer a specific research question. It uses explicit systematic methods that are selected with a view to minimizing bias, thus providing more reliable findings from which conclusions can be drawn and be made. अच्छा, आसान अल्फाज में systematic review ये होता है कि अगर एक टॉपिक के ऊपर मल्टीपल स्टडीज हुई भी हैं, ठीक है, और आप उन सारी स्टडीज के, फॉर एग्जांपल 20 स्टडीज हैं जो एक टॉपिक पे हुई भी हैं, और सबके रिजल्ट्स थोड़े बहुत मुख्तलिफ हैं, लेकिन आपको एक जवाब उस चीज का नहीं मिल रहा, ठीक है, आप चाहते हैं कि एक पर्टिकुलर मुझे जवाब मिले और मैं उसको सीखूं, ठीक है, उसका एक जवाब मैं निकालूं उस रिसर्च क्वेश्चन का जिसके ऊपर डिफरेंट पार्ट्स ऑफ द वर्ल्ड में डिफरेंट स्टडीज हुई भी हैं, उस चीज को एड्रेस करने का तरीका है सिस्टमैटिक रिव्यू, ठीक है। अब सिस्टमैटिक रिव्यू के अंदर ये होता है कि आप मल्टीपल स्टडीज को उठाते हो ठीक है, और उनके आंसर्स जो है वो एक जगह पे इकट्ठे कर लेते हो। फॉर एग्जांपल 20 स्टडीज में 20 स्टडीज की फाइंडिंग्स आप एक जगह के ऊपर इकट्ठी करते हो। ठीक है, अगर आप उसकी स्टैटिस्टिकल कॉम्बिनेशन करते हो तो वो मेटा एनालिसिस, अगर नहीं करते हो या नहीं हो पा रही है, उसका डेटा जो है वो बहुत हेट्रोजेनियस है कि आप उसको कोलेट नहीं कर पा रहे, स्टैटिस्टिकली कंबाइन नहीं कर पा रहे, तो दैट इज वहां पे फिर वो सिस्टमैटिक रिव्यू पे रुक जाता है। अगर आप कर लेते हैं, आप प्रॉपर उसको कोलेट कर लेते हैं, देन दैट इज अ मेटा एनालिसिस। सो व्हाई डू अ सिस्टमैटिक रिव्यू? देखिए ये सिंपल सी बात है कि एनिमल स्टडीज जो होती हैं वो हायरार्की के सबसे नीचे होती हैं और सबसे ऊपर होते हैं मेटा एनालिसिस एंड सिस्टमैटिक रिव्यूज। मेटा एनालिसिस एंड सिस्टमैटिक रिव्यूज आर यू नो ये एक एज प्री रैक होते हैं फॉर द एस्टैब्लिशमेंट ऑफ क्लिनिकल प्रैक्टिस गाइडलाइंस। ठीक है, तो ये हायरार्की और बड़े इजी टू पब्लिश होते हैं कंपैरेटिवली। जो रिसर्च हम यहाँ पे आरएमक्यू में करते हैं उसकी निस्बत अगर आप अच्छे जर्नल में पब्लिश कराना चाह रहे हैं तो इट विल बी वे इजियर टू पब्लिश अ मेटा एनालिसिस कंपेयर टू अदर क्रॉस सेक्शनल स्टडीज वगैरह। ठीक है, तो इसलिए हाईएस्ट फॉर्म ऑफ एविडेंस कंसिडर किए जाते हैं। ठीक है, जब क्लिनिकल प्रैक्टिस के गाइडलाइंस के जो एक्सपर्ट्स बैठते हैं वो गाइडलाइंस बनाते हैं तो उनका जो मेन उनका जो क्रक्स होता है जिसको वो देख रहे होते हैं वो सिस्टमैटिक रिव्यू और मेटा एनालिसिस होते हैं, इसीलिए ये बड़ी इजीली पब्लिश भी हो जाते हैं। स्टेप्स ऑफ अ सिस्टमैटिक रिव्यू। ठीक है, राइट अ प्लान फॉर द रिव्यू, सर्च फॉर स्टडीज, सिफ्ट एंड सेलेक्ट स्टडीज, एक्सट्रैक्ट डेटा फ्रॉम द स्टडीज, असेस द क्वालिटी। ठीक है, अब देखिए सिंपल मैं आपको बताता हूँ। सबसे पहले आपने एक अपना टॉपिक आइडेंटिफाई करना, उस टॉपिक की बेस पे आपने अपना क्वेश्चन बनाना। क्वेश्चन आपने बना लिया तो फिर आपने एक सर्च स्ट्रेटेजी रन करनी है और आपने रेलेवेंट लिटरेचर ढूंढना है। उस रेलेवेंट लिटरेचर को फिर आपने स्क्रीन करना है, फिर उसको उसमें से डेटा एक्सट्रैक्ट करना है और फिर आपने अपना मैन्युस्क्रिप्ट लिखना है। ठीक है, और डेफिनेटली उसकी सप्लीमेंट्री फाइल्स के लिए आपको क्वालिटी एविडेंस और रिस्क ऑफ बायस वो सब कुछ करना होता है, बट दैट इज नॉट द स्कोप ऑफ दिस वर्कशॉप। ठीक है, तो बेसिकली ये है कि आपको बस ये इसके मेजर स्टेप्स पता होने चाहिए। जो हम आज स्टेप की बात करें वो टेक्निकली उसका पहला स्टेप है कि टॉपिक आपने बना लिया, आप टॉपिक आपके पास आ गया, अब इसके बाद आपने पहला काम क्या करना है, यू हैव टू मेक अ पीको टेबल। तो ये हमारा आज का वो है। ठीक है, एग्जांपल्स एंड टाइप्स ऑफ क्वेश्चंस। ठीक है, इसके ऊपर ना जाएं आप टाइप ऑफ क्वेश्चन के ऊपर, ये एक्चुअली कॉकरेन का है। ठीक है, स्टैंडर्ड कॉकरेन का वहां से ये कॉपी हुआ है, तो इसलिए इसमें इस चीज पे ना जाएं कि टाइप ऑफ क्वेश्चन क्या है। ये है एक भी हम उठाते हैं, व्हाट इज द इंसिडेंस ऑफ लो बर्थ वेट इन माइनॉरिटी पॉपुलेशंस कंपेयर टू वाइट पॉपुलेशन। ठीक है, तो ये एक इंसिडेंस का वो है। इसमें से कोई एक क्वेश्चन हम उठा लेते हैं, व्हाट इज द इफेक्ट ऑफ प्रेगनेंसी ऑन एग्जैसरबेटिंग सिम्टम्स ऑफ मल्टीपल स्क्लेरोसिस। ठीक है, तो ये किसी भी किस्म का क्वेश्चन जो आपके जहन में आता है वो आप लेके उस पर सिस्टमैटिक रिव्यू कर सकते हैं। ठीक है, अगर आपको उसकी टेक्निक आती है। सिमिलरली इफ कॉफी कंजम्पशन यूजुअली एसोसिएटेड विद डेवलपिंग पैनक्रियाटिक कैंसर। ठीक है, इज एक्सरसाइज इफेक्टिव इन इंप्रूविंग क्वालिटी ऑफ लाइफ इन पर्संस विद सीओपीडी। तो ये इस तरह के क्वेश्चंस होते हैं। जो आपका कोई क्वेश्चन आपके जहन में आ रहा है, ठीक है, कोई भी क्वेश्चन आपके जहन में जो आ रहा है उसको आपने आंसर करना है और आप उसको चाह रहे हैं कि मैं इसके ऊपर जो प्रेजेंट लिटरेचर है उसको सम अप कर दूं, तो उसका आसान तरीका है कि आप उस पर सिस्टमैटिक रिव्यू कर दें और डेटा देख के फिर डिसाइड कर लें कि मेटा एनालिसिस हो रहा है या नहीं हो रहा। ओके, सो लेट अस कम टू द पीको। देखिए पीको के 4 वर्ड्स हैं, PICO। P stands for patients और populations और participants। I stands for intervention या फिर बाजू का जिसको PICO के बजाय PECO भी कर दिया जाता है। जब PECO होता है तो वो यूजुअली एक्सपोजर वाली स्टडीज होती हैं, उसमें अंदर I की जगह वो E कर देते हैं, दैट इज एक्सपोजर। C से कंपैरिजन ग्रुप कंपैरेटर, O से आउटकम। बाज औकात आपको SP लिखा मिलेगा, PICO S कर देंगे, S स्टैंड्स फॉर स्टडी डिजाइन या स्टडी सेटिंग। ठीक है, तो ये PICO C जो PICO है ये मोस्ट बेसिक वर्जन है, पीको इसको कहते हैं। अगर इसको आप अपने टॉपिक के लिहाज से मॉडिफाई करने पे आ जाए तो ये पीकोस PECO S वाला पीकोस भी हो सकता है, ये पीकोस SP एंड में आ सकता है, लेकिन नॉर्मली हम व्हाट वी यूज इज PICO पीको। अब व्हाट डू पीको मींस? देखें, जब भी आपने एक सिस्टमैटिक रिव्यू का टॉपिक आपने आइडेंटिफाई किया ना, पहला जो उसका स्टेप है दैट इज द टाइप ऑफ पीपल। आपकी पॉपुलेशन क्या है, किन मरीजों के ऊपर, किन लोगों के ऊपर आप अपनी स्टडी करना चाह रहे हैं। फॉर एग्जांपल डिफाइन कंडीशन और डिजीज इंक्लूडिंग एक्सप्लिसिट डायग्नोस्टिक क्राइटेरिया, पॉपुलेशन एंड सेटिंग ऑफ इंटरेस्ट, एज, रेस, सेक्स, कम्युनिटी, हॉस्पिटल, आउटपेशेंट। ठीक है, टेक्निकली पॉपुलेशन के अंदर आपके प्रोटोकॉल के अंदर ये सारी चीजें डिफाइंड होनी चाहिए। मैं फॉर एग्जांपल कहता हूं कि मैंने फॉर एग्जांपल लंग कैंसर वाले पेशेंट्स ले लिए, तो आप आपका सवाल है कि जी क्या स्मोकिंग से लंग कैंसर होता है, बड़ा पेट शुरू से दी जाने वाली एग्जाम्पल है। इसके अंदर आपकी पॉपुलेशन क्या है? आपकी पॉपुलेशन लंग कैंसर के पेशेंट्स है, ठीक है। अब पीको जो आपको सिस्टमैटिक रिव्यू आप करते हैं ना, तो आप ये नहीं कह सकते कि जो बस लंग कैंसर वाले पेशेंट मेरी पॉपुलेशन है। उसमें आपने ये बताना है कि आपके पास लंग कैंसर जो होगा वो डायग्नोज कैसे होगा पेशेंट्स को। आपने कहना है कि जी प्रॉपर आई डोंट नो व्हाट डू दे डू फॉर लंग कैंसर, मे बी सीटी स्कैन ही करते हैं। सीटी स्कैन डॉक्यूमेंटेड लंग कैंसर के जो पेशेंट्स होंगे या जिनकी स्टेजिंग डिटरमिन हुई होगी, प्रॉपर आप लिखेंगे कि इस डायग्नोस्टिक क्राइटेरिया के थ्रू जो फॉल करेंगे वो मेरी पॉपुलेशन होंगे, ठीक है। उसके अंदर एज ग्रुप मैं ये रखूंगा, रेस जो है उसकी मैं कोई फिल्टर्स नहीं लगा रहा, मैं उनकी क्यों इस चीज पे फिल्टर नहीं लगा रहा कि उनकी हॉस्पिटल प्रेजेंटेशन हुई है या स्क्रीनिंग में उनका पता चला। ये सारी चीजें आपने अपनी पॉपुलेशन में डिफाइन करनी होती हैं, ठीक है। सिमिलरली आ जाए कि टाइप्स ऑफ कंपैरिजन ग्रुप्स, ठीक है। फॉर ट्रायल्स प्लेसिबो स्टैंडर्ड थेरेपी, नो ट्रीटमेंट फॉर एपिडेमियोलॉजिकल स्टडीज, नो एक्सपोजर, नॉन केस, ठीक है। सिंपल वर्ड्स में कंपैरिजन ये है कि प्लेसिबो, अब छोड़े इनकी डिटेल्स में, आई डोंट थिंक सो दैट कम्स इनटू द वर्कशॉप स्कोप ऑफ द वर्कशॉप। सिंपल सी बात ये है कि कंपैरिजन ग्रुप कोई आपने ड्रॉ किया होना चाहिए, इसके बगैर भी हो जाता है, कंपैरेटर आपका ना भी हो तो भी हो जाता है, बट हो तो बेहतर है, ठीक है। फॉर एग्जाम्पल आप कहें कि मैं स्मोकिंग को कंपेयर कर रहा हूँ, चल इसमें एग्जाम्पल में इतना अच्छा फॉल नहीं करेगा, हम ऐसा कर लेते हैं कि हम दो ड्रग्स को कंपेयर कर लेते हैं फॉर ट्रीटमेंट ऑफ हार्ट फेलियर, ठीक है। लेट्स से मैं एटिनोलॉल को कंपेयर कर रहा हूँ वेरापामिल के साथ, ठीक है, फॉर एनी हार्ट डिजीज, फॉर कोरोनरी आर्टरी डिजीज, ठीक है। अब मैं कहूंगा जी एटिनोलॉल जो है वो मेरी इंटरवेंशन है और उसको मैं कंपेयर कर रहा हूँ वेरापामिल के साथ, ठीक है। तो ये कंपैरिजन ग्रुप का रोल है। अगर है तो बहुत अच्छी बात है, बड़ा सिंपल सा आपका ऑर्डिनरी सा मेटा हो जाएगा जो कि इजीली आप कर लेंगे। अगर नहीं है तो बिट्स ओके, तो उसको उसको सिंगल आर्म मेटा कहते हैं, वो भी आप उसको भी रिपोर्ट कर सकते हैं, ठीक है। एक्सपोजर्स और इंटरवेंशंस, ठीक है। आई मैंने आपसे कहा था कि आई को आप रिप्लेस कर सकते हैं ई के साथ, आई इंटरवेंशन भी हो सकता है, और अगर आप इसको पी ई सी ओ करके एक्सपोजर करना चाहें तो भी आप कर सकते हैं, ठीक है। एक्सपोजर अगर आपका है तो फिर आपको बताएंगे कि एक्सपोजर कितना आप एक्सपेक्ट कर रहे हैं। ये 15 साल पहले हुआ था, 20 साल पहले हुआ था, इंटरवेंशन आपने अगर दी तो सबक्यूटेनियस थी, इंट्रावेनस थी, कोई और उसका कोई और रूट था, अगर और डोज और इंटेंसिटी क्या थी, कितनी डोज लगाई, दिन में कितनी बारी लगाई, ड्यूरेशन ऑफ एक्सपोजर और थेरेपी कितने अरसे के लिए आपने लगाई, ये सब कुछ आपको अपने प्रोटोकॉल में डिफाइन करना होगा कि वो है जो मैं ले रहा हूँ। फिर टाइप्स ऑफ आउटकम्स, मैं देख क्या रहा हूँ, ठीक है जी। ये पॉपुलेशन मैंने सेलेक्ट कर ली, ये मैंने रिस्क फैक्टर्स, ये मैंने इंटरवेंशन सेलेक्ट कर ली, उसको मैंने इसके साथ कंपेयर किया, लेकिन किन चीजों की टर्म्स में मैं उस क्वेश्चन को गेज करूंगा, तो वो आपके आउटकम्स है। फॉर एग्जाम्पल ORR, ओवरऑल रिस्पॉन्स रेट होता है, कंप्लीट रिस्पॉन्स, ठीक है, चेंज फ्रॉम बेस लाइन कुछ होते हैं, ये सारे आउटकम वेरिएबल्स हैं, ठीक है। सर्वाइवल में आप आ सकते हैं, ठीक है, प्रोग्रेशन फ्री सर्वाइवल, ओवरऑल सर्वाइवल, ये सारे आपके आउटकम्स होते हैं, ठीक है। अच्छा, अब मैं आपको थोड़ा सा, क्योंकि अब हम अपनी पीको के ऊपर आते हैं, ठीक है। एक क्वेश्चन जो मैंने आपके लिए डिसाइड किया था, बड़ा पेट किस्म का क्वेश्चन है, हम जो जिस क्वेश्चन के ऊपर प्रैक्टिस करेंगे फॉर मेकिंग द पीको, इट इज एफिकेसी ऑफ बीटा ब्लॉकर्स इन हार्ट फेलियर पेशेंट्स। अब आप में से कोई है जो मुझे बता सकता है कि इसमें पॉपुलेशन हमारी कौन सी है इस सवाल में, एफिकेसी ऑफ बीटा ब्लॉकर्स इन हार्ट फेलियर पेशेंट्स? कोई भी चैट बॉक्स में बता, हमसा चैट बॉक्स खुला हुआ है?
जी, चैट बॉक्स हमने कर दिया था ओपन।
ओके, अगर कोई बता सकता है हार्ट फेलियर पेशेंट्स, बिल्कुल हार्ट फेलियर पेशेंट्स ऐसे ही है, तो आपके पास हार्ट फेलियर पेशेंट्स आपकी पॉपुलेशन है, ठीक है। अब जब आप लिखने पे आएंगे तो आप पूरा हार्ट फेलियर का बताएंगे कि हार्ट फेलियर से व्हाट डू आई मीन, मैं 55 की ये इजेक्शन फ्रैक्शन पे हार्ट फेलियर ले रहा हूँ या मैं 50 की इजेक्शन फ्रैक्शन पे हार्ट फेलियर ले रहा हूँ। बहुत सारी जगहों पे 40 तक भी वो हार्ट फेलियर नहीं लेके जाते, स्टेज 1 हार्ट फेलियर को भी वो मेटा एनालिसिस की स्टेज के लिए हार्ट फेलियर काउंट नहीं करते, क्योंकि वो यूजुअली एसिम्प्टोमेटिक होता है, ठीक है। मैं सिम्प्टोमेटिक पेशेंट्स ले रहा हूँ या नॉन सिम्प्टोमेटिक पेशेंट्स ले रहा हूँ, उनको वो डायग्नोज कैसे हुए हैं, ठीक है। वो इको के ऊपर मैंने उनको डायग्नोज कर दिया हार्ट फेलियर से, या मैं आगे एडवांस्ड इमेजिंग पे भी मैंने शर्त लगाई है कि ये होगा तो मैं हार्ट फेलियर डायग्नोज करूंगा। ये सारी डिटेल स्टडीज में होनी चाहिए, ठीक है। तो पॉपुलेशन हमारे पास डेफिनेटली हार्ट फेलियर है। दूसरी चीज मुझे बता दें आप, एफिकेसी ऑफ बीटा ब्लॉकर्स इन हार्ट फेलियर, इसमें इंटरवेंशन क्या है? बट इट्स वेरी ऑब्वियस, एक इंटरवेंशन, आपका कंपेरेटर भी नहीं है कि आप कंफ्यूज होंगे, एक ही हम उनको दवाई दे रहे हैं। क्यों, मुझे बता दे अगर कमेंट्स में। एडमिनिस्ट्रेशन ऑफ बीटा ब्लॉकर्स एक्सीलेंट, ठीक है। एडमिनिस्ट्रेशन ऑफ बीटा ब्लॉकर्स हमारी जो है वो है इंटरवेंशन है, ठीक है। एक्सपोजर यहाँ पे हम नहीं कहेंगे, ठीक है। एक्सपोजर यूजली रिस्क फैक्टर का होता है, ये जब आप डिटेल्स आगे हमारी सीरीज होगी उसमें आएंगे तो आपको पता लगेगा कब आपने एक्सपोजर यूज करना है, कब इंटरवेंशन यूज करना है, ठीक है, कब आपने बाकी चीजें यूज करनी है, ठीक है, कब आपने रिस्क फैक्टर की टर्मिनोलॉजी यूज करनी है। तो लेकिन इस सेक के लिए वी कॉल इट इंटरवेंशन। इंटरवेंशन बीटा ब्लॉकर्स हो गए, अब मैं अगेन उस डिटेल में नहीं जा रहा। आप जब आप डिफाइन करेंगे तो आपने प्रॉपर बताना है कि ओडी है, पीडी है, कितनी कौन सा बीटा ब्लॉकर कौन ले रहे हैं, कितनी बारी दिन में ले रहे हैं, कितनी डोज में ले रहे हैं, कैसे ओरल ले रहे हैं या आईवी ले रहे हैं, क्या ले रही है, सब आप बताएंगे। एंड तीसरी चीज कंपेरेटर। डू यू थिंक देयर इज एनी कंपेरेटर इन माय क्वेश्चन राइट नाउ? एफिकेसी ऑफ बीटा ब्लॉकर्स इन हार्ट फेलियर। देयर इज नो कंपेरेटर। अगर मैं ये करता ना एफिकेसी ऑफ बीटा ब्लॉकर्स वर्सेस डिजिऑक्सिन, ठीक है, या मैं कर देता आई डोंट थिंक सो कैल्शियम चैनल ब्लॉकर्स हार्ट फेलियर में नहीं यूज होते, कोई भी और ड्रग जो हार्ट फेलियर में यूज, फॉर एग्जांपल एस इनहिबिटर्स वर्सेस बीटा ब्लॉकर्स, तो हमारे पास कंपेरेटर होता। फिर एक को हम इंटरवेंशन के तौर पे डिफाइन करते और दूसरे को हम कंपेरेटर के तौर पे डिफाइन करते, या उसको हम कंपैरिजन ग्रुप बोलते या कुछ भी बोलते। ठीक हो गया, ये है। अब ये हमारे आपको हमें पता लग गया कि हमारी पॉपुलेशन क्या है, हमें पता लग गया हमारी इंटरवेंशन क्या है, हमें पता लग गया हमारा कंपेरेटर फिलहाल कोई भी नहीं है, और हमें पता लग गया कि अब हमारी आखिरी चीज क्या रह गई है, ओ आउटकम्स। तो आउटकम हम ऐसे जब भी डिफाइन नहीं करेंगे, हम ये कहेंगे कि जी हमारे आउटकम्स जो है वो एफिकेसी है। देखिए, दो यूजुअली जो मेटा एनालिसिस होते हैं वो दो चीजों पे होते हैं, एक सेफ्टी होती है और एक एफिकेसी होती है, ठीक है। सेफ्टी वर्सेस एफिकेसी, क्योंकि अगर हमें सारी चीजें इसमें ऐड करता जाता ना तो फिर ये पीको टेबल हमारा बहुत कॉम्प्लेक्स हो जाता और इट वुड हैव बीन टू मच फॉर द फर्स्ट टाइम। तो मैंने उसको क्या किया है, मैंने उसको मतलब सिर्फ हमने एफिकेसी रखा है। तो हमारा टॉपिक है एफिकेसी ऑफ बीटा ब्लॉकर्स इन हार्ट फेलियर पेशेंट्स, सिस्टमैटिक रिव्यू, ठीक है। और हमारा जो आउटकम है वो एफिकेसी है, सही है। तो ये चक्कर है। अब ये सारी कहानी समझाने का मकसद था आपको मैश समझाना कि मैश क्या होता है। मेडिकल सब्जेक्ट हेडिंग्स यहां से भी मैं एक बार रीड कर लेता हूँ। इज अ कंट्रोल्ड एंड हायरार्किकली ऑर्गेनाइज्ड वोकैबुलरी प्रोड्यूस्ड बाय द नेशनल लाइब्रेरी ऑफ मेडिसिन। होता इस तरह से है कि पबमेड के पास लाखों नहीं करोड़ों में आर्टिकल्स होते हैं, ठीक है। तो पबमेड ने क्या किया हुआ है, पबमेड ने एक बैंक बना दिया, ठीक है, और मतलब उसने एक वर्ड्स का बैंक बनाया और जो भी उनके पास नया आर्टिकल आता है उसको वो उस मैश के बैंक में से कुछ वर्ड्स अलॉट कर देते हैं, ठीक है। और उसकी मदद से पबमेड के ऊपर आर्टिकल छानना आसान हो जाता है, ठीक हो गया। ये होती है मैश, सिनोनिमस टू एम्प्टी टर्म्स इन एमबीएस, ठीक है। आप अब यही देखिए, मैश का जो वर्ड है ना, ये वाला मैश, दैट इज एक्सक्लूसिव फॉर पबमेड, ठीक है। यही काम के डेटाबेस जो मैनेज कर रहे हैं बंदे, वो हर आर्टिकल को 2-3 मेन टर्म्स दे देंगे जिससे उनकी शिनाख्त होगी, ठीक है। जैसे फॉर एग्जांपल होता है ना कि हम 5 सालों के बच्चे हैं, 5 साल के मेडिकल स्टूडेंट्स हैं, ये तो नहीं होता ना कि हमें बस आरएमयू के अंदर डाल दिया जाता है, आगे हमारी मजीद सेग्रीगेशन नहीं होती। हमारी ईयर्स की बेस पे सेग्रीगेटेड होते हैं हम, कुछ फर्स्ट ईयर के होते हैं, कुछ सेकंड ईयर के होते हैं, कुछ थर्ड ईयर के होते हैं। इसी तरह डेटाबेस के अंदर मैश की बेस के ऊपर आर्टिकल्स डिवाइड हुए होते हैं, ठीक है। और उस पर्टिकुलर मैश के थ्रू आप उस रेलेवेंट डोमेन के आर्टिकल्स को इजीली एक्सट्रैक्ट कर सकते हो। दिस इज व्हाट मैश इज। तो इट इज सिनोनिमस टू एम्प्टी टर्म्स इन एमबीएस। एमबीएस इसको जो है वो एंट्री कहता है, सिनाहिल आई थिंक सब्जेक्ट टर्म्स कहता है, और कॉकरेन आई थिंक सो मैश ही कहता है। तो ये लेकिन बहरहाल हमारा जो इसको स्कोप है दैट इज मैश। तो सिनोनिमस कीवर्ड्स इन एंट्री टर्म्स। अच्छा, एक और बात मैं आपको बता दूं, दिस इज इंपॉर्टेंट फॉर यू टू नो। कीवर्ड्स क्या होते हैं? होता अक्सर इस तरह से है कि कुछ टॉपिक्स नए आते हैं, जैसे अभी हम एक मेटा एनालिसिस पे काम कर रहे थे, इट वाज अबाउट इंटरएट्रियल शंट डिवाइसेस जो कि रिसेंटली लॉन्च हुई हैं। अभी तक पबमेड ने उसके लिए कोई मैश इजाद ही नहीं किया। स्पेशली रिसेंट लिटरेचर के अंदर जो चीजें होती हैं उसके अंदर इस तरह होता है कि पबमेड ने उनको अभी तक कुछ मैश अलॉट नहीं किए होते, तो एब्स्ट्रैक्ट्स ऐसे ही पड़े होते हैं। लेकिन अगर एक आर्टिकल आया है पबमेड वालों के पास और उन्होंने देखा कि किसी मैश में फिट नहीं हो रहा ना, उन्होंने उसी एब्स्ट्रैक्ट में से 2-3 वर्ड्स निकाल के उसको कीवर्ड्स दे देने हैं। तो इन केस कोई रिसेंट लिटरेचर है या कोई ऐसा इग्नोर्ड कंपोनेंट है जिसके ऊपर आपको मैश नहीं मिल रहा या जिसके ऊपर लिटरेचर कम है, इनफैक्ट बेशक वो पुराना टॉपिक है लेकिन उसके ऊपर इनफ लिटरेचर नहीं है, तो उस केस में आप कीवर्ड्स की तरफ जाते हैं। एब्स्ट्रैक्ट के एंड के ऊपर हेडिंग होती है कीवर्ड्स की। जब आप ज्यादा नीचे पबमेड पे जाते हैं, अभी आपको दिखा देंगे, तो आपके पास मैश वर्ड्स होते हैं लेकिन इमीडिएटली नीचे कीवर्ड्स होते हैं, ज्यादातर होते हैं, कभी कभी नहीं भी होते। और जब आप डेटाबेस सर्च करते हैं मैश के ऊपर, ठीक है, मैश का अलग आपको मैश के उस खाने में जाना पड़ता है पबमेड के ऊपर, तो उसके साथ अक्सर आपके पास एंट्री टर्म्स आती हैं। वो ये इंडिकेट करती हैं कि ये चीजें जो हैं ये इस मैश से मिलती जुलती हैं लेकिन स्लाइटली डिफरेंट हो सकती हैं। उन सब की सब एंट्री टर्म्स को, बेशक वो 50 भी हैं, आपको वो अपनी पीको टेबल में डालनी पड़ती हैं और आपको उसको स्ट्रेटेजी बनानी पड़ती है। ठीक है, अभी कीवर्ड्स और एंट्री टर्म्स थोड़ा सा और जो है वो इजी हो जाएगा जब हम जो है पबमेड पे चलेंगे। ठीक है, मेरी स्क्रीन मूव कर रही है?
जी जी, मूव
हमजा
कर
मेरी
रही है,
स्क्रीन?
कर रही है।
ओके, तो अभी हम पबमेड पे जाते हैं। ये पबमेड का इंटरफेस है, ठीक है, यहाँ पे आप जाएंगे, एडवांस्ड में भी हम जाएंगे, लेकिन पहले हम लोग नीचे जाते हैं मैश डेटाबेस के अंदर। हमारा क्वेश्चन क्या था? एफिकेसी ऑफ बीटा ब्लॉकर्स इन हार्ट फेलियर पेशेंट्स। ठीक है, पहले रुके मैं आपको एक जरा मॉडल सा वो दिखा देता हूँ, पिको मॉडल। हाँ, ये देखिए, ये होता है पिको टेबल दिखाने के लिए। अब यहाँ पे PICOS, इसमें एस भी डला हुआ है, चलें एस हम भी डाल देंगे। पबमेड मैश टर्म्स, एंट्री, कॉकरेन, सिनाहिल, कीवर्ड्स, सर्च डेट्स, बिगिन, ये सारे इसके कंपोनेंट्स होते हैं पिको टेबल के। अभी फिलहाल ये खाली है, ठीक है, इसमें कुछ भी नहीं है, लेकिन ये अभी हम थोड़ी देर में हम हैंड्स ऑन इसको भर देते हैं। ओके, सो अब हम, ये आपने देख लिया, आपको नजर आ गया ये सारा। अभी हम जाते हैं वापस पबमेड के ऊपर। देखिए, ये मैश है। सबसे पहले हम पॉपुलेशन को आइडेंटिफाई करते हैं, ठीक है। सबसे पहले हम पॉपुलेशन को, 1 मिनट मुझे दें, 1 मिनट बस। ठीक है, तो अब हमारी पॉपुलेशन क्या आती है? हमारी पॉपुलेशन थी हार्ट फेलियर। तो हम देखें, इट हैज टू बी मैश। यहाँ पे आपको मैश नजर आ रहा है ना, ये मैश वाला ही होना चाहिए क्योंकि अभी आप मैश सिलेक्ट कर रहे हैं। मैं डालता हूं हार्ट फेलियर, हार्ट फेलियर, ठीक है, हार्ट फेलियर आ गया। देखें, ये मैश में है ना, ठीक है, ये मैश में है। तो आपने हार्ट फेलियर को पकड़ा और आपने इसको यहाँ पे, ये अब देखिए, अगर ये मैश ना होता ना तो ये आ जाता नो टर्म्स फाउंड या नथिंग, कुछ इस तरह, लेकिन ये आ गया तो मतलब ये मैश डेटाबेस में एक प्रॉपर वर्ड इंट्रोड्यूस्ड है। ठीक है, इसको हम एक ओपन लिंक न्यू टैब में भी कर देते हैं और इसको मैं डाल देता हूँ ऐड टू सर्च बिल्डर। ठीक है, अब देखिए, हार्ट फेलियर मैश है, यहाँ पे पबमेड सर्च बिल्डर में आ गया, यहां से आपने इसको कॉपी करना है, ठीक है। एंड आपने ना इसको पबमेड पे भी हम कर रहे हैं और हमारी पेशेंट्स जो हैं वो है मैश टर्म्स हैं, तो यहाँ पे आपने इसको डाल देना। ये देखिए, हार्ट फेलियर मैश, ठीक हो गया। लेकिन अब एक और मैंने आपको बताया कि दिस इज नॉट इनफ। ये खाना आपको नजर आ रहा है कीवर्ड्स का जो मैं हाईलाइट कर रहा हूँ, आपको अपने पिको टेबल में इसको भी भरना पड़ता है। इसके लिए व्हाट यू विल बी डूइंग इज, हार्ट फेलियर आपने डाल दिया, आपने यहाँ पे लिख दिया ऐड टू सर्च बिल्डर, ओ सॉरी, ऐड टू सर्च बिल्डर आपने कर दिया, आपने कर दिया सर्च पबमेड, ठीक है। 1,45,822 रिजल्ट्स। ये देखें एंट्री टर्म्स, ये होती हैं एंट्री टर्म्स, नजर आ रही है जो मैंने हाईलाइट किया है। इन ये सब के सब आपकी कीवर्ड्स में इंक्लूडेड होनी चाहिए। यहाँ पे फॉर द सेक ऑफ सिंप्लिसिटी, एक तो हमने टॉपिक भी बहुत ही ब्रॉड लिया है, ठीक है, जो हमें ऑलरेडी पता है, बट आई वाज ट्राइंग टू कीप इट सिंपल। तो आपने अभी फॉर नाउ हम पहली 3 टर्म्स डालेंगे, ठीक है। ये कार्डियक फेलियर आपने उठाया, कॉपी किया और आपने अपने मैश में डाल दिया, ठीक है। इसकी फॉर्मेटिंग खराब ना हो इसलिए मैं इसको ये यहाँ से ये रिमूव कर, ठीक है। उसके बाद मैं दूसरी एंट्री टर्म मैंने डाली हार्ट डीकम्पनसेशन, तीसरी एंट्री टर्म भी मैं डाल देता हूँ, दैट इज मायोकार्डियल फेलियर डाल देते हैं, ठीक है। अब आपकी स्ट्रेटेजी क्या होनी चाहिए? आपकी स्ट्रेटेजी ये होनी चाहिए कि ये कोई 10-15 टर्म्स है, 1 2 3 4 5 6 7 8 9 10 11 12 13 जो 15 टर्म्स है, वो सारी की सारी आपने अपने पीको के अंदर डालनी है, ठीक है, कीवर्ड्स के अंदर आपने डालनी है यहाँ पे। बट क्योंकि हमारी वर्कशॉप टोटल 45 मिनट्स की, जिसमें से जस्ट है 15 मिनट्स लेफ्ट, तो मैं ये सारी नहीं डाल रहा। बट आई सपोज मैं ये कर लेता हूँ कि मैंने ये वाला जो भी 2-3 के साथ किया, ये मैंने सबके साथ किया, ठीक है। और ये हमने सर्च पबमेट कर दिया, ठीक हो गया। अब हम यहाँ पे एडवांस्ड में जाते हैं, ठीक है। और वो जो टर्म्स मैंने यहाँ पे कॉपी की थी ना, कार्डियक फेलियर, यहां से आपने वैसे आपको एक मजे की बात बताऊं, फॉर द सेक ऑफ कंप्लीटिंग द पीको टेबल हम उन सबको यहाँ पे डालते हैं। आप वहां से डायरेक्ट दूसरी टैब में खोल के भी कॉपी पेस्ट कर सकते हैं, ठीक है। और दूसरा तरीका ये होता है कि आपने एरर्स को मिनिमाइज करने के लिए कोशिश करनी होती है कि हमेशा आप कॉपी पेस्ट ही करें। देयर इज अ डिफरेंस कि अगर यहाँ पे कार्डियक फेलियर जो है ना, एक बैक स्पेस भी ज्यादा हो गई है तो इट्स डिफरेंट नाउ। हार्ट डीकंपनसेशन का डी छोटा हो गया, इट्स डिफरेंट नाउ, ठीक है। ये फिर वो चीज नहीं रहेगी जो हम चाह रहे हैं। तो अभी हम लोग ऐसा करते हैं कि कार्डियक फेलियर हमने आई थिंक कॉपी कर लिया था, हमने कार्डियक फेलियर कॉपी किया और हमने यहाँ डाल दिया, ठीक है। इसको हमने कहा सर्च करो जी कार्डियक फेलियर को। कार्डियक फेलियर पे 3,19,211 आर्टिकल्स आ गए। फिर हम एडवांस में गए, दूसरा हमारा था हार्ट डीकंपनसेशन, ठीक है। उसके ऊपर हम गए, उसको हमने दोबारा इंटर सर्च टर्म किया, और ये देखिए इस टाइम ये ऑल फील्ड्स, इट्स नॉट मैश, इट्स नॉट टाइटल एब्स्ट्रैक्ट, इट्स नॉट लाइक दैट, ठीक है। आपने इसको भी सर्च कर लिया, हार्ट डीकंपनसेशन, ठीक है। और तीसरी आपने क्या, मायोकार्डियल फेलियर नहीं हुआ, आपने इसको यहां से कॉपी किया एंड आपने फिर एडवांस में आप गए और आपने इसको यहां से मायोकार्डियल फेलियर भी कर दिया, ठीक है। अब देखिए 3,19,211 आर्टिकल्स। अब ये आपके पास देखिए एक मैश टर्म्स हैं और 2 एंट्री टर्म्स हैं। अब अगर आप इस पॉपुलेशन को प्रॉपर्ली सर्च करते ना, तो ये कोई आपके पास 15 एंट्रीज यहाँ पे हो जानी थी। लेकिन सिंप्लिसिटी के लिए अगेन मैं आपको बता रहा हूँ, ये आपने नहीं करना कि आप पता लगे पहली 2 उठाएं और बाकी छोड़ दें, आर्टिकल्स मिस हो जाते हैं इस तरह, ठीक है। अब मैंने क्या किया, मैंने किया ऐड क्यूरी, नहीं कोशिश क्या करें, पहले मैश वाली क्यूरीज आए, ऐड क्यूरी। अब देखिए आपने डालना है ऐड विद और, क्योंकि ये सारी सिनोनिमस टर्म्स है ना, तो आपने और लगाना है। आई होप कि आपको बुलियन ऑपरेटर्स आते होंगे इस टाइम पे, ठीक है। अगर नहीं आते तो मैं थोड़ा सा बता देता हूँ। 3 मेन बुलियन ऑपरेटर्स होते हैं, एंड और नॉट। नॉट इतना ज्यादा यूज नहीं होता, लेकिन एंड और बहुत यूज होते हैं। ऐसी आप एंड आप वहां पे लगाते हैं जब आप ऐसे आर्टिकल्स चाह रहे हो कि जिसमें जिन 2 चीजों में आप एंड लगा रहे हो उनमें दोनों वो हो, ठीक है। फॉर एग्जाम्पल आप ऐसा चाह रहे हैं कि मुझे ऐसे आर्टिकल चाहिए जिनमें हार्ट फेलियर भी हो और बीटा ब्लॉकर्स का भी जिक्र हो, तो फिर आप एंड से कंबाइन करेंगे। लेकिन अगर आप ऐसे चाह रहे हैं कि ऐसे आर्टिकल मुझे मिले जिनमें हार्ट फेलियर का भी जिक्र हो, या मायोकार्डियल फेलियर का जिक्र हो जाए, या हार्ट डिकम्पनसेशन का जिक्र हो जाए, या कंजेस्टिव हार्ट फेलियर का जिक्र हो जाए, तो आपको और लगाना पड़ेगा, ठीक है। मायोकार्डियल फेलियर हो गया और आप हम लगा देते हैं ऐड विद और। ये आपकी पहली सर्च क्यूरी बन गई। सर्च आपने किया, देन यू गो विद 3,20,264 रिजल्ट, ठीक है। अच्छा, अब हम यहाँ पे हमारा पॉपुलेशन के लिए हमने सपोज कर लिया कि 15 की 15 हम फिलहाल डाल चुके हैं। अब हमारा पॉपुलेशन के लिए इन 5 में से एक एस्पेक्ट पूरा हो गया। अब हम जाते हैं इंटरवेंशंस के ऊपर, ठीक है। अब वापस हम मैश में आ गया। मैंने आपको क्या कहा था कि बीटा ब्लॉकर्स हैं, एड्रीनर्जेनिक बीटा ब्लॉकर्स, ये एक ही चीज है, ठीक है। ये आ गए, ये भी हमारे पास मैश पे अवेलेबल है। आई मेड श्योर कि हम वही टर्म्स करें जो मैश पे अवेलेबल है, ठीक है, बिकॉज इट्स जस्ट अ बिगिनिंग एंड इट्स जस्ट द पहला स्टेप। यहाँ पे आपने इसको सिलेक्ट किया और सबसे पहले आपने कर दिया ऐड टू सर्च फिल्टर। यहां से कॉपी करके पहला काम आपने करना है कि आपने अपने पीको टेबल में डाला, ठीक है। आपने पीको टेबल में आए, इंटरवेंशन पे आ गया। अब आपने इसकी एंट्री टर्म्स पे जाना है, ठीक है। इसको आपने क्लिक किया, अच्छा नहीं, उसको ऊपर हमने सर्च पबमेड भी कर देते हैं। ठीक है, 4,43,278 रिजल्ट्स। ठीक है, अब देखें एड्रिनर्जेनिक बीटा एगोनिस्ट, इन चीजों में मन जा रहा है रिस्ट्रिक्ट टू मैच मेजर टॉपिक, ये इसका अलग सीन होता है कि कुछ होते हैं वो उसको एडिशनल टर्म्स के तौर पे रजिस्टर करती है परमिट, कुछ को वो कहती है हाँ ये इसका मेजर टॉपिक है। अगर आप सिर्फ वो कर रहे हो तो यहाँ पे आप लगाएंगे तो 2-3 हजार और कम हो जाएंगे। ठीक है, अब देखिए एंट्री टर्म्स पे आ जाए, कितनी ज्यादा एंट्री टर्म्स हैं, कोई 50-60 एंट्री टर्म्स हैं। जो कॉकरेन की रिकमेंडेशन है उसके मुताबिक ये सारी की सारी एंट्री टर्म्स आपके पीको में होनी चाहिए। ठीक है, आपको पीको में ये सब होनी चाहिए, बट फॉर द सेक ऑफ सिंप्लिसिटी मैं सिर्फ 3 ले रहा हूँ। ठीक है, फॉर एग्जाम्पल कॉपी, और इसको अभी आपने कीवर्ड्स में डालना है। देखें ये मैश है और ये कीवर्ड्स है। कीवर्ड्स एंट्री टर्म्स जो है फॉर नाउ हम लोग उनको कहते हैं कि वो सेम ही है। एड्रिनर्जेनिक बीटा एगनिस्ट्स पहले 3 सिर्फ लेते हैं। ठीक है, बीटा और ये बिल्कुल सिमिलर होंगे। ये देख के आपने छोड़ नहीं देना कि जी ये जो एक एक कॉमा करके इन्होंने फर्क कर दिया, इसकी बेस पे फर्क आपके रिजल्ट्स पे आ जाएगा। ठीक है, तो ये सारे लेना जरूरी है। और उसके बाद हम और एक और भी उठा लेते हैं, ब्लॉकेटर वाला उठा लेते हैं। ठीक है, अच्छा अभी जो हमने पॉपुलेशन के साथ गेम प्ले किया है ना, जो पॉपुलेशन के साथ अभी हमने गेम प्ले की है ना, वही एग्जैक्टली अब हम प्ले करेंगे उसके साथ अपना इंटरवेंशन के साथ। देखें, अच्छा अब हम वहां से उठा लेते हैं, यहाँ पे वो आया नहीं, आई थिंक बैक कर दिया था मैंने। ठीक है, इसको यहाँ पे हम कॉपी करते हैं। ठीक है, अब जब मैं वहां से बेशक कॉपी भी करूँ, ये मैश के ये ब्रैकेट लगे हुए हैं ना, तो ये मैश ही पे सर्च होगा। ठीक है, ये 40 ये हो गया, अब ये इसकी हिस्ट्री में आएगा। ठीक है, देखा अब ये आ गया। अब हम उसकी जो 3 टर्म्स हमने वहां से ली थी ना, वही हम आपको वो करके दिखाता हूँ। कॉपी, सर्च, क्या 96,000। देखिए कहने को वो सेम लग रहा था, लेकिन सिर्फ इसका सीक्वेंस बदलने से ऑलमोस्ट रिजल्ट्स डबल हो गए, डबल से भी बल्कि ज्यादा हो गए। ठीक है, कॉपी, क्या 96,000। अच्छा उसके बाद आखिरी वाला हम ब्लॉकेड, ठीक है, इसको भी हमने सर्च किया। अब हमने, अब ये काम आपने सारी की सारी के साथ करना है जब आप अपना मेटा एनालिसिस करेंगे। ठीक है, अब हम क्या करते हैं, अब हम अब देखिए ये जो नंबर 4 वाली क्यूरी है ना, जिसपे हमारे पास 3,20,264 रिजल्ट्स हैं, ये हमने, वो हमारी तमाम पॉपुलेशन इस पे आ गई है, और हमारी इंटरवेंशन जो है उसके लिए अब हम डालते हैं, इसको हम करते हैं ऐड क्यूरी, और ये तीनों ऊपर वाली हम ऐड विद और किए जाएंगे, ऐड विद और, ऐड विद और। ठीक हो गया, और इसको हम सर्च करेंगे 96,000 रिजल्ट्स। ठीक है, अब इंटरवेंशन के लिए 96,000 रिजल्ट्स आ गए हैं, और पॉपुलेशन के लिए 3,20,000 समथिंग रिजल्ट्स आ गए। देखिए अब मैं वापस जाता हूँ मैश के ऊपर। अब मैं कहता हूँ अच्छा चले, अब हम थोड़ा सा हम वो कर लेते हैं कंपैरिजन। हमने फिलहाल कुछ किया नहीं है, आउटकम्स को फॉर नाउ मैं ड्रॉप कर रहा हूँ। ठीक है, फॉर नाउ हम आउटकम्स को ड्रॉप कर देते हैं। ये चलें आज ऐसा करते हैं, 1-2 बल्कि चलें ड्रॉप कर देते हैं, बिकॉज वी डोंट हैव इनफ टाइम। ठीक है, ठीक है, अब हम ऐसा, अब फॉर एग्जांपल आउटकम अगर आप करेंगे ना, तो आउटकम आप कर देंगे, फॉर एग्जांपल मैं एफिकेसी देख रहा हूँ, तो एफिकेसी इजीली आपको आ जाएगी। ठीक है, फॉर एग्जांपल मैं डाल के देखता हूँ एफिकेसी, देखें एफिकेसी ट्रीटमेंट, ये वही सीन होगा कि ये आपकी मैश टर्म आ जाएगी और इसके नीचे आगे ट्रीटमेंट्स हो जाएंगे। ये भी टेक्निकली आपको डालनी चाहिए, बट हम ऐसा करते हैं कि हम स्टडी टाइप पे चले जाते हैं। फॉर एग्जांपल मैं कह रहा हूँ नहीं भाई मैं बड़ा हाई क्वालिटी मेटा एनालिसिस करना चाह रहा हूँ, नॉट गोइंग टू कॉम्प्रोमाइज ऑन द क्वालिटी, तो मुझे सिर्फ और सिर्फ रैंडमाइज्ड कंट्रोल्ड ट्रायल्स चाहिए, ठीक है, नॉट एज अ टॉपिक। अगर आप एज टॉपिक पे जाएंगे तो वो जो कमेंट्स होते हैं कि किस तरह होने चाहिए, कैसे होने चाहिए, वो वाला आ जाएगा। पब्लिकेशन टाइप मुझे चाहिए, बिल्कुल जी, ऐड टू सर्च बिल्डर, ये आपने कॉपी यहाँ से करके, ये सिर्फ मुझे रैंडमाइज कंट्रोल ट्रायल्स चाहिए, ये आपने यहाँ पे करना, ठीक हो गया। अच्छा, इसके नीचे एंट्री टर्म्स मोस्ट प्रोबेबली नहीं होनी, ठीक है, इसके नीचे आप खुद बना सकते हैं, ठीक है। आप एडवांस सर्च बिल्डर में जाके आप खुद ये टर्म्स बना सकते हैं, ठीक है। एक मैं आपको बना के भी दिखा देता हूँ, मैं आपको करता हूँ कि प्लेसिबो कंट्रोल ट्राई कर देता हूँ, कंट्रोल प्लेसिबो रैंडमाइज्ड ट्रायल, ठीक है। 1,00,000 1,81,665, ठीक है। तो अभी बहरहाल, और ये चीजें टेक्निकली जो है ना मुझे उधर कॉपी करनी चाहिए थी, प्लेसिबो कंट्रोल ट्रायल वाली वर्डिंग, ठीक है। प्लेसिबो रैंडमाइज ट्रायल, अब मैं खुद हाथ से लिख लेता हूँ क्योंकि मैंने इसको कॉपी नहीं किया, तो ये भी आप कर लें, प्लेसिबो रैंडमाइज्ड ट्रायल, ठीक है। तो अब आप अगर आपको, अब यहाँ पे लेसन क्या है कि अगर आपको एंट्री टर्म्स नहीं मिलती है ना, तो आपने कुछ चंद एक टर्म्स अपने से थोड़ा दिमाग यूज करके ना इसको पबमेड TW कर देगा ब्रैकेट में, TW मींस टेक्स्ट वर्ड, कि आपने खुद अपना टेक्स्ट इजाद किया, दैट इज ओके टू, ठीक है। हर चीज के ऊपर मैश नहीं होती, हर चीज के ऊपर कीवर्ड्स नहीं होते, हर चीज के ऊपर एंट्री टर्म्स नहीं होती, तो ये भी आप कर सकते हैं, बट पहली प्रायोरिटी डेफिनेटली आपकी वो होनी चाहिए। अब हम जाते हैं सर्च स्ट्रेटेजी के ऊपर, ठीक है। अब हमारा अच्छा वाला पार्ट आ रहा, एक मिनट, रैंडमाइज कंट्रोल ट्रायल को हम डालते हैं ऐड क्यूरी, ठीक है, और इसको हम डालते हैं प्लेसिबो कंट्रोल ट्रायल को ऐड विद और, ठीक है। ये और भी बहुत सारे बन सकते हैं, कंट्रोल ट्रायल, क्लिनिकल ट्रायल, वो सारे 5-6 वैसे यूजुअली आपको डालने चाहिए, लेकिन अभी यहाँ पे टाइम नहीं है तो उसको हम छोड़ देते हैं, और सर्च किया, ठीक है, 6,45,000, ठीक है। अब देखें, एक क्यूरी जो हमारी मेन स्टडी टाइप की है उस पर 6.5 लाख रिजल्ट्स हैं, हमारी इंटरवेंशन की क्यूरी पे 96,000 रिजल्ट्स हैं, और हमारी पॉपुलेशन की क्यूरी पे 3,20,000 रिजल्ट्स हैं। अब मैं इन सबको कंबाइन करूंगी, ठीक है। सबसे पहले मैं पॉपुलेशन को डालता हूं ऐड क्यूरी, ठीक है। उसके बाद मैं डालता हूं, अब मैं क्या करूंगा, ऐड विद एंड लीड्स टू रिडक्शन ऑफ रिजल्ट्स, ऐड विद एंड, ये जो है ना, ये इसको यहां से आपने सारी को कॉपी करना है, और ये आपकी टेक्निकली सर्च स्ट्रेटेजी है पबमेड के लिए, और आपने अपने पीको टेबल के जहां पे ये सर्च स्ट्रेटेजी लिखा है ना, इसके बिल्कुल नीचे इसको पेस्ट कर देना। ये आपकी सर्च स्ट्रेटेजी है जो आप सप्लीमेंट्री फाइल के अंदर अपने मेटा एनालिसिस में पब्लिकेशन के लिए जब भेजेंगे तो आप देंगे। अब देखते हैं कितने रिजल्ट्स आते हैं, 1,01,166 ओनली। अब देखा हमने किस तरह से 3-3.5 लाख रिजल्ट्स को, 6-6.5 लाख रिजल्ट्स को अपने हिसाब से एडजस्ट करके सिंपल एक डिसर्नेबल नंबर जिसको आप डील कर सकते हैं वो आपने बना दिया, 1,01,066। अब इसकी सिंपल अगला तरीका ये होगा, वो हमारा टॉपिक नहीं है कि हम इसको सेंड टू करके साइटेशन मैनेजर पे भेज के इसकी स्क्रीनिंग स्टार्ट करेंगे। 6.5 लाख आर्टिकल्स को पढ़ के आप स्क्रीन नहीं कर सकते। ये सर्च स्ट्रेटेजी रन करने का मकसद ये होता है कि वो सारे आर्टिकल जो आते हैं वो आपको रीड करने पड़ते हैं कि ये मेरे सिस्टमैटिक रिव्यू में घुस सकते हैं या नहीं घुस सकते। 6.5 लाख, 3 लाख या 90,000 आर्टिकल रीड करना इज आउट ऑफ क्वेश्चन, इम्पॉसिबल है। तो ये टेक्निक्स आप यूज करके जो मैंने आपको अभी सिखाई है विद मैश टर्म्स, एंट्री टर्म्स वगैरह वगैरह, आप देखें कि हमने ऑलमोस्ट 6.5 लाख रिजल्ट्स को नैरो डाउन कर दिया 1,01,166 के ऊपर। और ये आप इसकी स्क्रीनिंग शुरू करेंगे, पहले इसकी प्राइमरी स्क्रीनिंग होगी, सेकेंडरी स्क्रीनिंग होगी, और ये जो है ना ये बड़ी इंपॉर्टेंट होगी। आप अपनी सप्लीमेंट्री फाइल के अंदर ये वाली सर्च स्ट्रेटेजी जो है ना वो देंगे, ठीक है। एक और भी आप दे सकते हैं, मैं आपको बताता हूँ। ये आप जब जाते हैं ना, एक आपकी जब सर्च टर्म आएगी, इसको आप क्लिक करेंगे तो ये लंबी वाली होती है, ये वाली जो सारी है, ये भी आप कॉपी कर लें तो अच्छी बात है, लेकिन यूजली इसको नहीं किया जाता, ठीक है। ओ सॉरी, बस इसीलिए नहीं किया जाता कि ये हाल होता है। ठीक है, बहरहाल इस सबको अगर आपने नहीं, ठीक है, हाँ यहाँ पे ये कॉपी हो गई, ठीक है, इसको मैंने कॉपी किया और आप इसको अपने पिको टेबल में डाल सकते हैं, सर्च स्ट्रेटेजी, और उसके बाद आप लिख सकते हैं डिटेल्ड सर्च, कहाँ गया, जी, ठीक है, उसके अंदर आप इसको पुट कर दें, ठीक है, ये आपके हैं और आप, ये आपका एविडेंस है कि मैंने ये काम किया। अब देखिए, अगर मैं इसमें कंपैरिजन तो है नहीं, लेकिन अगर मैं ट्रीटमेंट एफिकेसी आउटकम्स वगैरह भी डाल देता हूँ ना, तो ये रह जाएगा कोई लगभग, यकीन मानिए 400-500 पे आ जाएंगे, ठीक है। तो ये पिको टेबल का फायदा आपको क्या है, एक तो पिको टेबल का फायदा ये है कि आपके पास एमबीएस की एक्सेस नहीं है। अभी आपने ये वाला हिसाब सिर्फ पबमेट पे करके मैंने आपको दिखाया है, ठीक है, इस पे कितने हमें टाइम लगा, 20 मिनट लगे हार्डली, ठीक है। यही काम आपने पबमेड सॉरी एमबेस जो है वो एंट्री के लिए है, कॉकरेन मैश टर्म्स, सिनाही ऊपर सब्जेक्ट टर्म्स, ये सारा काम अपनी बारी बारी जो अपने आर्टिकल्स है वो एक जगह जमा करने हैं, ठीक है। हमजा मेरी आवाज आ रही है?
जी जी, जवाद, इफ यू कुड काइंडली मूव टुवर्ड्स क्लोजिंग इंशाल्लाह, ताकि नेक्स्ट सेशन स्टार्ट
हाँ
हुए।
बस जा रहे हैं, हो गया, खत्म हो गया। तो बस यही मैं पिको टेबल था, आपको बना के भी मैंने दिखा दिया, ठीक है। इसके अंदर टेक होम देखिए, सिंपल इसको मैं समराइज 2 मिनट में करूँ तो यही है कि आपको मैश के ऊपर आपकी ग्रिप होनी चाहिए, ठीक है, मैश मैश के ऊपर आपकी ग्रिप होनी चाहिए, एंट्री टर्म्स, की टर्म्स, कीवर्ड्स का आपको पता होने चाहिए। दिस वाज द सिंपलेस्ट वर्जन ऑफ पिको टेबल, ठीक है, इतनी आसान नहीं होती। बहुत सारे आपके पास जो टॉपिक एक्चुअली हॉट होते हैं आजकल के दौर में, जो पब्लिश होने का जिनका चांस होता है, उनके ऊपर अक्सर इस तरह होता है कि आपको मैश ही नहीं मिल रहा होता, वो नए नए ट्रायल्स आए होते हैं, नई ड्रग्स पे होते हैं, उसकी अलग स्ट्रैटेजीज होती हैं, ठीक है। लेकिन वो एक लेटर पार्ट में हम 7-8 दिन की वर्कशॉप्स करेंगे, उसके अंदर उन सारी हम जो जो पोटेंशियल मसले हो सकते हैं उनको हम डील करेंगे इंशाल्लाह ताला, ठीक है। तो लेकिन ये एक सिंपलेस्ट, एक फॉर द इंट्रोडक्शन पार्ट, एक आपको एक्सपोजर देने के लिए दिस वाज द बेस्ट, ठीक है। तो ये यहाँ पे खत्म हो गया, इसको 1 मिनट में मैं समराइज कर देता हूँ। आपने अपने रिसर्च क्वेश्चन आइडेंटिफाई करना है, उसमें आपको पता होना चाहिए कि मेरी पॉपुलेशन क्या है, मेरी इंटरवेंशन क्या है, मैं कंपेयर कर रहा हूँ किसी इंटरवेंशन के साथ कि नहीं कर रहा, मैं कौन आउटकम क्या देख रहा हूँ, मैं उसकी सिर्फ सेफ्टी एडवर्स इवेंट्स वगैरह देख रहा हूँ या मैं उसकी ट्रीटमेंट एफिकेसी भी देख रहा हूँ। उस लिहाज से आपने उसके मैश और कीवर्ड ढूंढने हैं, उनकी सर्च स्ट्रेटेजी बनानी है और आर्टिकल्स डाउनलोड कर लेने हैं, और साथ साथ आपने अपना पिको अपडेट रखना है, ठीक है। ये पिको देखिए, हमारे पास एमबीएस की एक्सेस नहीं है, ये पिको आपने सिर्फ फाइल के तौर पे किसी ऐसे बंदे को भेज दिया ना जिसके पास लाइब्रेरी की एक्सेस है एमबीएस की, जो एल्सवियर वाली है, तो वो इजीली इसकी बेस के ऊपर आपको एमबीएस से सारी सर्च स्ट्रेटजी रन कर देगा विद इन 5 to 6 मिनट्स, अगर वो एक्सपर्ट है तो। ये चक्कर है, ठीक है। बस ये हेयर इट एंड्स, होपफुली इट वाज अ प्रोडक्टिव सेशन फॉर ऑल ऑफ यू। मैं 2-3 मिनट में आपके क्वेश्चंस जो है वो आंसर करने की कोशिश करता हूँ। 1 मिनट एंट्री
Jawad,
टर्म्स
we
की।
are out of time. Inshallah, we will answer all your questions by sending them to Jawad. And Jawad, हम उन्हें फिर writing में जो है read back कर लेंगे participants को. Time का थोड़ा सा
ओके,
constraints है हमारी. बाकी I think we'll wrap up the session here. Thank you, Jawad, for such an enlightening session on a topic that is very rarely practiced, and it's very important to the research that we will be conducting as doctors and as we progress in our career. Thank you, Jawad.
थैंक यू सो मच फॉर हैविंग मी।
Thank you. Now we'll move towards our next session. Before we move on, I would just like to send an announcement for all the participants of the poster competition and case report competition. Your sessions are starting, so kindly enter the breakout rooms. You can find the breakout rooms and enter your specific room. And inshallah, the poster and the case report session will be beginning there. So now if the surgery interest group would kindly take over.
Assalamu alaikum. Am I audible?
Yes,
Yes, so far you are audible.
This is Wafa Khan. I'm third year MBBS student at Rawalpindi Medical University. I would like to introduce today's speaker. We have with us Dr. Mohammad Waqas Ilyas, who is a senior fellow trauma and orthopedician at the University Hospital Southampton, United Kingdom. He's an expert in his field with a passion for utilizing the latest advancements and techniques to improve patient outcomes.
In his talk today, Dr. Mohammad Waqas Ilyas will be discussing the state of the art in orthopedic surgery. He will be sharing his insights on the latest trends and development in his field. We are fortunate to have you here today to share your knowledge with us. Over to you, sir.
Thanks a lot, everyone. I'm just gonna try to share my screen. Can you give me some access to do that for me? Guys, can you hear me?
Yes, sir. We can see your screen, sir. It is visible.
Good. I don't know whether you can see the screen or not.
Yes,
Because
sir.
I don't
Your
think
screen
that
is visible. We can see
Is it only my name visible, or is it the whole topic visible on the screen?
Sir, currently your name only.
Only my name. That is the issue. I think there is some technical glitches. I may have to go with this thing. I'm unable to complete my full screen share because the information is gonna miss on that one. Can you see the screen now?
Yes, sir. Now we can see the whole.
You can see the whole screen. Okay, so good morning, everyone. Thanks a lot for taking some time and attending my talk. I'm sure that some of you have already gone out to the breakout sessions to present your posters and other presentations. So I was asked to give a talk regarding recent advances and state of art in orthopedics. It is a very vast topic, and within the span of 30 minutes, I don't think I can completely cover that. And considering the target audience is medical students and house officers, so I have narrowed it down to robotics and orthopedics, and I'm just going to give you an introduction to that. I'm not going to go into much details of it because, again, it will be too technical. It will have a lot of terminology that I'm sure that you people won't be familiar with. So yeah, I have tried to make it as simple as possible so you have some basic understanding of robotics developments in orthopedic surgery. So first of all, my conflicts of interest, I don't have any, although during this presentation, I am going to show you some robots that are from one particular company, and they are designed and being operated over the last 20 years. I have some experience of using those robots, but I am not an expert yet because the learning curve is quite a lot and you need a lot of volume of doing these sorts of surgeries to be confident saying that, oh, I am the expert in this field now. So just starting with a very light note, any one of us that chooses to become an orthopedic surgeon, we are usually come across a fractured patient and you say that, oh, I want to fix that one. Because once you fix it or stabilize that fracture, you notice a sudden improvement in their symptoms. And that improvement, they say, okay, with minimal intervention, I have made his life better. Okay, so that is the primary reason that you come towards orthopedics, because of the immediate results. But orthopedics is a lot more broad specialty than just fractures. This is our basic tool, the hammer of Thor. Whenever you see a nail, you need to hit it. So your hammer is already ready, always ready. And some surgeons, they were so impressed by the Thor's hammer that they have taken that hammer, sterilized it, and used it intraoperatively in their procedure. This is the father of modern orthopedics, Sir John Charnley. And on the left side, you can see The Man and the Hip. This is the book written on him and on his whole career, that it all started with a simple idea that he came across some arthritis patients, and he thinks that I want to improve their quality of life. And he come across with the first ever designed total hip replacement that is right in his hand there. He started experimenting on his implant design. He come across multiple hurdles, he comes across multiple complications, but rather than giving up, what he did is that he kept on pursuing. He looked at his results and he said, okay, where I am getting wrong, okay, and he continued improving his technique, so that total hip replacement is one of the most successful procedures in orthopedics right now. Again, just a simple presentation of a total hip replacement and a total knee replacement. Relatively straightforward procedures in most of the population, but if the deformity is quite worse and if the anatomy is quite distorted, that could be quite challenging. Till last 20 years ago, everyone was doing manual total hip replacements and manual total knee replacement. But over the last 20 years, the role of robotic surgery came in, especially joint replacements, because by using robots, you can make your cuts more precisely. You can pre-plan your surgery, and you can execute those pre-planned procedures intraoperatively, and you can see that there is massive improvement in the outcomes. So 20 years ago, invasion of robots came in. Just again, on a lighter note, multiple Transformer series that over the series of Transformers, you can see that the robots evolve. Okay, and this is what is going on with the orthopedic robots as well, that with every passing year and new engineering and IT skills, these robots are getting more and more intelligent, and they are giving you more precise results. Just an article reference, a clinical application of robotic orthopedic surgery. This is by Cheng et al., published in 2021 in Musculoskeletal Disorders Journal. He included 224 clinical studies, all the way back from 2000 to 2019. He figured out that there are currently 14 types of robots that were used in orthopedic surgeries. Mako was the most widely used robot in hip and knee surgeries, and Mazor is the most common robot used in spinal surgery. So here in this picture, you can see the Mako robot. Mako comes with multiple extensions. Okay, this is the simplest, most basic extension. On the screen, this area here, that is the reference, you can say reference electrodes. What you do is that for robotic surgery, you need a cross-sectional imaging for planning and the procedure beforehand. So you get the CT scan, you pre-plan the procedure, and then intraoperatively, you have to guide the robot where the anatomical landmarks are, so that the robot can identify those landmarks and a robot can guide you and assist you during the whole procedure. These are the two screens that usually gives you information whether you are going according to your plan or whether you are undercutting the bones, whether you are overcutting the bones. And there is an automatic stop mechanism in that robot as well, that it won't allow you to, if you are deviating from your pre-operative planning, it won't allow you to cut the bone. It will prompt you to double check that if you are happy by deviating from your pre-operative planning. Another article reference, Mako robotic arm knee arthroplasty system. Martin Roche, he looked at the outcomes. That is back in 2021 again. presented in Orthopedic Trauma Surgery Journal. The Mako system allowed for improved implant placement utilizing the CT guidance. It improved bone resection accuracy. It gives a flexibility for functional implant placement with gap balancing. And when combined with kinetic sensors, there were improved rotation and soft tissue balance as well. So all in all, it is giving all the positive outcomes that you usually desire from a joint replacement surgery. Another article reference, Journal of Arthroplasty 2022, they compare the postoperative instability and acetabular cup positioning and robotic assisted versus traditional total hip arthroplasty done by Jonathan et al. 3-surgeon cohort study. They included 2,247 consecutive patients. Out of those, 1,700 odd patients had manual total hip arthroplasty, and 523, they underwent a robotic assisted total hip arthroplasty. They figured out that a robotic total hip arthroplasty resulted in less than 1/4 the dislocation rate as compared to the manual total hip arthroplasty, and no revision. But they couldn't find any differences in outcomes for patient-reported outcome measures or any other early complications. So all in all, it shows that you are reducing the dislocation rate by putting the implants in more accurate position and more desired positions, but long-term patient-reported outcome measures are not that different. So principles in Mako robotic assisted surgery. Number one, like I said earlier, there is pre-operative 3D planning that you need to do on a CT scan. Okay. The second is EcuStop haptic technology. That is the advances in engineering. Like I said, that if you are cutting too much, the robotic arm is going to freeze in between and it won't allow you to cut that. Okay, till it prompts you to double check whether you are wanting that desired cut in your arthroplasty procedure. And intraoperative registration of bony landmarks, these are through those sensors that I showed you earlier. Employ the robotic for precision cuts. Okay, so if you are doing it manually, the risks are that your angles may be a little bit different than what you desire. Your hands may become a little bit wobbly or shaky, and you may angle it slightly different. That will result in a disaster. Insightful data analytics. It gives you a real-time comparison as compared to your preoperative planning. So it is right in front of you on the screens. So it is guiding you throughout the whole surgery. Just a picture of preoperative CT scan for a hip arthroplasty planning procedure. This is the screen that you are going to see. It gives you what orientation you are putting the implant in. For example, here cup inclination is 40 degrees, that it is going to guide you. Cup version is 20 degrees. Superior, how many millimeters you want to cut superiorly. Medially, how many millimeters you want to medialize your acetabular component. And posterior, again, how many millimeters you want to posteriorize your acetabular component. So all these plannings you have done already beforehand, looking at the CT scan. And intraoperatively, the robot is just going to guide you that, oh, you have achieved your preoperative planning. And here is the intraoperative execution. Again, here you can see these sensors, they are identifying the bony landmarks intraoperatively, and they are going to guide you. With all these fancy procedures, there are a few disadvantages as well, especially when you try to implement these procedures in Pakistan, like countries where we don't have much resources and the health services are government funded, and government is not allowing you to buy those robots and training the people. Number two, the volume of the surgery or arthroplasty surgery is not great in one particular center. So you have to justify that you are buying a $1.25 million robot and whether you are going to make good use of that robot or not. So it is very expensive for the setup to build in. Number two, the company that is supplying those robots, they are charging you about $100,000 for annual maintenance of the equipment. And for each case of arthroplasty, you are approximately spending about $1,000 of equipment that is completely not reusable in the next procedure. So you can imagine that at the moment, comparing the dollar rates, you are utilizing about disposable equipment that is worth $3,000 just for one procedure on the robot. That doesn't include the implants cost. So it is quite a expensive procedure to undertake, especially in Pakistan. Again, like I said, a regular upgradation and calibration is needed. So you need a trained engineering and IT staff for that. Learning curve, it is a little bit longer for surgeons and staff as well. And intraoperative setup time, it also adds up. For example, if you are doing a manual hip arthroplasty or a knee arthroplasty procedure, you may be able to finish it within 60 to 90 minutes. But if you're using a robot, you may add about another 30 minutes to your surgical time. So a slightly prolonged anesthetic time and a slightly prolonged surgical time. But the benefits are that if you are aiming for precision and accuracy, then in the long term, you are giving your patients the best possible results through that procedure. Just to conclude, robotic surgery is an excellent and exciting new prospect and a constant improvement and development. There are lots of engineering team and a lot of IT team who are constantly working on that. It has its own pros and cons. Considering cost-benefit analysis of individual centers and their caseloads, it will take over traditional manual surgery in the near future. Many thanks. I tried to keep it simple. If you have any questions, I'm here. I'm happy to answer.
Assalamu alaikum, sir. I have some questions. I'm Ahmad Dar from second year MBBS, Albany Medical University. So I would like to ask some questions from you, which are one of the participants I have asked. One of them is, do orthopedic surgeons have a very hectic life? Do they have a good work-life balance?
It all depends where you are working. If you consider that you are working in Pakistan and on top of your normal job, you also have to involve in private practice, then in the initial years, it will be quite hectic because you have to give a lot of time to your private practice to begin with. So it is a little bit demanding to begin with, but I have seen quite a lot of orthopedic surgeons, even in Pakistan, who got very good work-life balance. So you will choose at some point in your life that, oh, okay, I need to spend more time with my family as well. I am not working or operating over the weekend, for example, Saturdays and Sundays. It is all regarding the management. So even if you are involved in private practice and you say, okay, my clinic will run only from 4 o'clock till 8 o'clock, and I'm not going to stay after 8 o'clock, okay, because I have to go home early. I will have my dinner with my family. So you just need to set up those rules, okay. It may be the case that you may not earn that much, okay, but you will have a good work-life balance. So you have to choose what sort of life you want to live, and whether you want to be an orthopedic surgeon as well. As part of your normal jobs, you will be an on-call rota for the rest of your life. That means that your registrars or your trainees, they may call you in the middle of night and say that, oh, I got a complicated trauma patient who got multiple long bone fractures. Can you come in the middle of night and help me out? So you may have to go at that point. Again, I am in UK. They have reduced the working hours quite significantly. You are not allowed to work more than 48 hours average per week. That means that I am only on call once in a month over the weekends. And today is one of my weekend on call. So I will be leaving for hospital very soon.
Thanks a lot, sir. There's one more question, and I think it's a very interesting question. that what's your point of view about that? Will robotic surgery eventually remove the need for the orthopedic surgeons in the hospitals?
So they are having very good results out of it. Okay, the main thing with robotic or arthroplasty surgery is that you want to get it right the first time around. You don't want to mess around. Okay, so the primary index procedure is the most important procedure. If you can make the primary procedure as good and as accurate as possible, then it will change the life of your patients, and you don't want any complications afterwards. Okay, because if you start running into complications in orthopedics, especially risks of infections or dislocations, then going back again doing the same implants and changing the implants, it becomes quite hectic. So get it right the first time, spend some time. If you have availability of robots, do all that planning beforehand, and try to execute your plan intraoperatively, and you will be happy at the end of the day.
Right, sir. So there's a one more. That what are some of the latest advancements in the orthopedic surgery that you are particularly excited about in the UK?
So before coming to UK, when I was looking at the you can say limb recon surgeries, it was only a Lisdorf frame. That is quite an old instrumentation, you can say. The technology has gone quite ahead now. They are using hexapod frames now here. They are using computerized softwares to guide your can say limb alignments and deformity corrections. We are using here motorized lengthening nails to increase the leg lengths. That is the other thing. I have come across especially oncology procedures, although if they have a prognosis of more than 6 months, then you are going all the way. I have seen total femur replacements even on those procedure on those patients. So there is a lot going on in orthopedics, partly because our engineering teams, they are a lot more involved in medical equipments, so they come up with more and more sophisticated implants, and those implants are giving you better outcomes and better results. One reason. Number two, IT teams, they are involved with the orthopedics very closely now. So you are seeing a lot more advancements in prosthetics. For example, you can try to control even after a upper limb amputation, you are trying to control those prostheses using the stimuli from your nerves rather than the mechanical stimuli that we used to rely on, or just a cosmetic prosthesis. Rather than we have moved a lot more towards the functional prostheses in upper limbs. Same goes for the lower limbs. The advancements in the implants, you may have come across some Paralympic games that they are running around faster than you or me using the carbon fiber blades prosthesis. So there is a lot going on. If you are interested in orthopedics, you won't be disappointed coming into the field.
Yes, so thanks very much. So this is end of the session, and thank you a lot, sir, for your precious time that you gave us an honor by spending some of their time. And
No
I
worries.
think that's the end of the session. And thanks again, sir.
No worries. Take care. Have a lovely day. Bye, guys.
Over to you, Hamza bhai.
Now we'll be moving towards our quiz session. If the moderators of the quiz could kindly open their mics and cameras and take over. Thank you.
Assalamu alaikum. Am I audible?
Yes, you are.
First of all, I'd just like to welcome all the quiz participants, and please make sure that you have your team number in your name so that we can identify you easily. Within the next minute, you have to turn on your mics and turn on your cameras as well. So please make sure that you do that. Meanwhile, the moderators that I have with me, Nida, Alian, Amna, and Aiza, I think. Are you all here? Just say yes if you are.
Yes.
Yes. Yes, we are.
Okay, excellent. Please remember your duties. We'll begin in 2 minutes once the team members have written their names and their team numbers. All quiz participants are requested to please turn on your cameras and your mics. Okay, team number 2, are you over here? The team lead can speak or a team member, it doesn't matter.
Yes, we're here.
Okay, team 3.
Yes.
Team 4.
No, yes.
Team 4.
Yes, I'm here.
Team 5.
We're here.
Okay, team 6.
Oh.
Team 6.
Yeah, very perfect.
Team 7.
Yes, we're here.
Team 8. Team 8. Hello. Team 9. I'm just going to share my screen for the first round. Is my screen visible to all of you?
Yes.
So team 1. Team 1 is unavailable. They have opted to drop out of the quiz. So team 2 will now go first. And so we'll begin with team 2, team 3, team 4, and so on. Team 9, or is team 9 here? I think we should start. That's fine.
नानी इधर कॉलेज से वापस आई इतना मुझे गुस्सा था मतलब सीनियर के बाहर क्या मसला है हम लोग कौन सा में भाग रहे हैं
Okay, I'm going to explain the rules briefly. There are 7 questions for one team. Now, when one team is answering, let's say it's team 2, I need everyone else to turn off their mics. Your cameras must stay on, but your mics must be off. Only team 2's mics will be on. We have moderators who will be monitoring and making sure that all your cameras are on. If we find that your camera is off for more than 5 minutes, you will be penalized with negative marking. And if your camera or your mic stays off, if your mic stays off during your turn or your camera stays off throughout the quiz for more than 20 minutes, you may be liable to disqualification. So you've been warned. 7 questions per team. You will have 15 seconds. A moderator will announce once 10 seconds have elapsed, and once 15 seconds have gone by, they will say next slide, after which you will not be given any extra time. And in case of any ambiguous answer, if your team members are talking over each other, the team lead's answer will be considered final. Usman Liaquat, who is with me, will be making sure to note down your points, and he will be tallying your points and any negative marking that you may have to face. Nida, I think you should start with the introductions and then we'll begin with the quiz.
Assalamu alaikum, am I audible?
Yes, you are.
All right. Welcome everyone. I'll go with the introductions first. We have Usman Liaquat Bhai. He is from final year MBBS. He's the head of research development department for surgery interest group. And we have Aisha Muhammad, who will be looking, who is also from RMU. She's in 4th year MBBS and she's the general secretary for surgery interest group. They'll be presiding over the session. Handing over to you, Aisha.
Okay, so it says team 1 in the next slide, but I want team 2 to start. So team 2's team lead, can you please just say if you're here, confirm if your team members are here as well?
Yes, we're all here.
Okay, excellent. We're going to start and please remember to make your answers clear. Say the entire option, don't just say A or B. Okay?
Okay, yes. B.
10 seconds.
A. D.
Ten seconds.
A.
Next line.
B.
Ten seconds.
D.
Now team 3 will participate.
Team 3, can you just make sure that all of you are here? Can the team lead confirm that the team is here? Are your cameras on? Are your mics on? Team 3? Mariam Zafar, your team lead for team 3. Mariam Zafar. Okay, we'll move on to team 4. Usman bhai, just remember we need to get team 3 at the end. Team 4, Tamim bin Nasser. All right, you're here.
Yes.
Okay, we're about to begin.
Okay. D. D.
Ten seconds.
Alpha.
Vision loss. Delta.
Ten seconds.
Delta. Delta. Charlie.
10 seconds.
Charlie.
Beta. 10 seconds.
Beta.
Charlie.
We'll be moving on to the next team. Team 3, are you available right now? Or Mariam Zafar? Wait, Minal, team 5?
Yes, we're here.
Okay, we're going to start. Are your team members here as well?
Yes.
Okay, we're going to start.
Is it team 5?
Yes, it's team 5. Minal is the team lead.
A.
10 seconds.
A.
A. Ten seconds.
A.
A.
B.
B. Ten seconds.
D.
B.
Next
slide. B. C. 10 seconds. Next slide. C.
E. B. Beta.
B.
A.
A.
All right, thank you. We move on to team 6 from CMH, I think. Ania. Walaikum assalam. You're the team leader, I'm supposing. Are your team members here?
Yes, all are here.
Okay, we're going to move on then. This is team 6. Usman bhai, team 6.
Yeah. Proceed.
What's the name of the second one? So, C. He's a feature at feature.
10 seconds.
A. Urology. B.
Ten seconds.
Okay. B. A. Abstain.
10 seconds.
B. Transvestite. C. Cholecystectomy. A.
Ten seconds.
C.
You can skip the question and the
A.
second question have been asked.
10 seconds.
C. Infections of
For the last question, I think it's repeated in the slide. So
It's
for that,
additional.
we'll award grace marks for that. Emma Disease Team 7, you're up next.
All right.
We're here. Ahmed Disease Team 7. Your entire team is present?
Yes.
Okay, we're going to start now. Team 7.
Ten seconds.
D.
10 seconds.
D. C.
10 seconds. Next slide.
A.
10 seconds.
B.
B.
C.
10 seconds. D.
Thank you. We're going to move on to Team 8, Jannat Fatma.
Yes,
University
we're
of
here.
Lahore. Okay, is your team present?
Yes.
Okay, we're going to start now. Team, you are Team 8.
A. C. Ten seconds. Next slide. C. 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 A. Ten seconds. D.
Okay, thank you. We're going to move on to Umar Abab, Team 9. Umar Abab, is Team 9 present? Team 9. Is Team 3 present? Mariam Safar?
Yes, I'm back.
Okay, Mariam
I
Safar.
lost my turn.
Yeah, we'll take your turn right now. Is your team
Okay.
here?
It's just me.
Okay, it's just you. All right.
Yeah.
We're going to start right now. Your Team 3.
Okay. C. Tonsillitis. B. Sinusitis. B. Neurosurgery. D. Eating and drinking. C, A, B,
Okay, thank you, Mariam. Abab, team 9. Team 9, Abab. Message. Give us 1 minute, please.
Is team 1 and team 9? Team 9 is present.
Team 9 is present. Team 1 dropped out before the quiz. And Mariam, Abab, team 9, she isn't responding right now. I think we should just move on then. Give us 3 minutes. We're going to announce the top 5 teams. We'll move on to the visual round. Thank you for your patience. We just need 3 minutes. I'm sorry for the delay, everyone. We'll be announcing the top 5 teams shortly. Thank you for your patience. Assalamu alaikum, everyone. Thank you for waiting. So team 9 has been disqualified because they were unable to turn up. Team 1 said that they would not participate, so we were left with a total of 7 teams. Out of those 7 teams, now we have team number 3, team number 5, and team number 7, who have all gotten 30 points. And then we have team number 6 and team number 8 with 25 points. So team 3, 5, 7, 6, and 8, you will qualify to the next round, the visual round. The other participants, you may turn off your cameras now and you may keep your mics muted. Teams 3, 5, 7, 6, and 8. Are you present here? Team 3?
Yes.
Team 5?
Yes, we're here.
Team 7?
We're here.
Team
We're here.
6? Team 6?
Yes, team 6 is here.
And team 8?
Yes, we're here.
We're going to start with the visual round in a minute. I will explain the rules. Okay, so the visual round, the rules are pretty much the same. We're going to have 5 slides per team, 5 stations per team. It's like an OSPE station. You'll have an image or a diagram. The diagram may have something labeled on it, such as A or B, and you'll have to identify the labeled vessel or nerve. It may be a simple instrument. So you'll have 15 seconds, just like the last round, and each station has 5 marks. And in case of any ambiguous answer, team lead's answer will be considered final. We're going to start with team 3. Team 3, are you here?
Yes, I'm here.
Okay. Usman Bhai, team 3, and whoever was noting the time, please make sure that you're on top of that. Thank you.
TBLS interior.
It's in purple color. You're asking in purple.
Hey, sorry if there was any confusion. The purple muscle.
Oh, okay, the one in purple. So, flex, I don't know, extensor helices or something. I don't know.
Can you make a clear answer?
You have the option to say next slide.
Next slide.
Extensor helices. Okay, next slide. In blue. Cerebellum.
Kindly read the
Yes. How many
question
lobes does the
first.
structure have?
Oh my God, 3. I'm sorry, I didn't read the question.
10 seconds.
It's a laryngoscope. Non-absorbable. Laryngoplasty.
Okay, thank you, team 3. We move on to team 5. Team 5, are you here?
Yes.
Yes.
Team 5 will start now.
Deeper on your left.
10 seconds.
Deeper on your left. Fibula.
Fibula. Age. Age of the patient.
Condition regarding
10
regarding the
seconds. Next slide. This was the Lobotomy.
It was ABC, airway, breathing, circulation.
Airway.
Thank you. Now we move on to team 6. Team 6.
I have one.
Okay, we'll start now.
Ten seconds.
Last third part of the radial. Radial nerves. Radial nerves. Endotracheal. Endotracheal. पिछले वाले endotracheal. Scalpel. Scalpel. It's a scalpel. Tube thoracotomy. Needle thoracotomy. Needle thoracotomy.
Thank you. We now move on to team 7. Team 7.
Yes.
We'll begin.
Yes.
Ten seconds.
The blue part, that's what I was saying. Advanced trauma life support. You make sure that the patient is conscious and then you move on to the ABCs, which is the airway, breathing, and circulation. Or if he's not choking on his stomach.
Kindly make a precise and first answer. The first priority.
Make sure the patient is unconscious.
Okay.
Laparoscopy.
Thank you. We'll now move on to the final team, team 8. Team 8, are you present?
Yes, we are present.
Okay.
Yes.
We're going to start now.
The tube in the curved shape.
Near the spleen.
10 seconds. Next slide. Next. Retino. 10 seconds. वो था 10 seconds. Distribution. Urine bag.
Okay, thank you, teams. We will now announce the top 3 teams. We'll move on to the rapid fire round. Just give us 3 minutes. Thank you. Thank you for your patience. I will now announce the top 3 teams. So the 3 teams will be moving on to the rapid fire round are Team 3, Team 5, and Team 7. Team 3, Team 5, and Team 7, you will move on to the rapid fire round. Is Team 3 present?
Yes, I'm here.
Team 5?
Yes, we're present.
And Team 7?
Yes, we're here.
Okay, congratulations. So the rapid fire round. For this round, there will be no slides. You will have a time frame of 100 seconds. I will ask you questions and you have to give an answer. I will give you 2 options. There will be a question. I will announce the 2 options and then you have to pick the right one. You will have 100 seconds to answer as many questions as you can, and whichever team gets the most questions answered correctly will win. Are the rules clear?
Yes. You will be asking the questions?
Yes, I will ask the questions, I will state the options, and then you have to pick the right one.
Okay.
The team that gets
the next
yes.
question.
We will.
As soon as you pick one option, we move on.
What if I don't pick any option?
You can say next question.
Okay.
You can pause. You can say pause. There's only 2 options. Quick question. There are 2 options. You pick one and the other.
Okay.
Just give me a second while I open up questions. We will begin with Team 3. Team 3, Mariam Zafar.
Yes.
We'll start with you. Whoever's noting the time, when you've started your stopwatch for 100 seconds, please do say start so that I can start.
Start.
Surgical procedure performed on the spine to relieve pressure on the spinal cord. Laminectomy, vertebroplasty.
Laminectomy.
It is commonly indicated for brain surgeries. Craniotomy, appendicitis.
Craniotomy.
Is deep vein thrombosis a potential post-operative complication? Right, wrong?
Yes, right.
Laparoscopic cholecystectomy, a minimally invasive procedure used for the removal of the spleen or the gallbladder. Laparoscopic cholecystectomy. Spleen, gallbladder.
Gallbladder.
Surgical procedure used to open narrowed or blocked blood vessels. Bypass, angioplasty.
Angioplasty.
Robotic assisted surgery primarily used for open heart surgeries. Right or wrong? Robotic assisted surgery is endoscopic sinus surgery indicated for the treatment of sinus-related conditions or cardiac arrhythmias.
Sinus-related conditions.
Is laser surgery commonly used for the treatment of cataracts? Right or wrong?
Yes, right.
Is post-operative infection a common complication following surgery? Right or wrong?
Right.
Surgical repair for hernia called meningotomy, herniography.
Herniography.
Is an arthroscopy a surgical procedure used to examine and treat conditions of the gastrointestinal tract? Yes or no?
No.
Is robotic assisted surgery a recent advancement in surgical techniques? Yes or no?
Yes.
Is tracheostomy primarily performed to create an artificial opening in the esophagus? Yes or no?
No.
Is the splenic vein responsible for carrying nutrient-rich blood from the spleen to the liver?
No.
Inferior vena cava carries oxygenated blood from the lower body to the heart. Right or wrong?
Wrong.
Sutures typically used
Time's
for
up.
closing deep. Okay. So we had 15 questions in your case. We're going to move on to the next team.
I have a question.
Team 5?
Team 5, yes. Can my team members speak up or only am I supposed to speak?
If you want to nominate a team member to play on your behalf, you may, but only one team member can take part in the rapid fire round.
Okay. Then I'll go.
Okay. Please do let me know when to start.
Yes, I'm ready.
Sutures typically used for closing deep tissue layers during surgery, absorbable or non-absorbable?
Absorbable.
Is the semitendinosus muscle responsible for hip abduction? Right or wrong?
Wrong. Right. Wrong.
Is Trendelenburg positioning characterized by the patient being placed in a prone position with the head lower than the feet? Is Trendelenburg positioning characterized by the patient being placed in a prone position with the head lower than the feet?
Yes.
Thin layer of connective tissue lining the inner surface of bones is called endosteum or periosteum.
Endosteum.
One person needs to answer, please. Soleus muscle located in which compartment of the leg, anterior or posterior?
Anterior.
Is the tricuspid valve located between the left atrium and the left ventricle? Yes or no? Is the tricuspid
Yes.
valve located?
Yes.
Does the
No, 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 no.
one person will answer, please. Does the temporomandibular joint allow for movements like rotation and translation? Yes or no? Temporomandibular joint allow for movements like rotation and translation?
Yes.
Is the ulnar artery commonly used for arterial blood gas sampling? Yes or no? Ulnar artery
No.
arterial blood gas sampling. Is the hepatic portal vein responsible for carrying out nutrient-rich blood from the digestive system to the liver?
Yes.
Does the superior vena cava carry oxygenated blood from the upper body to the heart?
Yes.
Is the sartorius muscle responsible for flexing the knee joint?
Yes. Time's up.
Okay. Time's up. We will now move on to the last team, team 7.
Yes.
Okay, team 7, you have 100 seconds. Let me know when to start, please.
I'll start.
The one who's keeping.
Start.
Yeah, I got it.
Is the periosteum a thin layer of connective tissue covering the outer surface of bones? Yes or no?
Yes.
Is the popliteus muscle located in the posterior compartment of the leg?
Yes.
Is the tricuspid valve located between the right atrium and the right ventricle?
Yes.
Does the temporomandibular joint allow for movements like chewing and speaking?
Yes.
Is the radial artery commonly used for arterial blood gas sampling?
Yes.
Is a tourniquet used to restrict blood flow during surgery?
No.
Which is responsible for producing insulin, spleen or the pancreas?
Pancreas.
Is the ulna a bone located in the lower leg?
No.
Are scrubbing and gowning necessary steps before entering the operating room?
Yes.
Who prevents food from entering the trachea during swallowing, glottis or epiglottis?
Epiglottis.
Is disinfection the process of eliminating all microorganisms, including spores? Yes or no?
And next question.
Is a scalpel a common surgical instrument used in the operating theater? Yes or no?
Yes.
Is cochlear implant surgery a common procedure in ophthalmology? Yes or no?
I didn't hear the question.
Is
Next.
is laminectomy a procedure performed in neurosurgery? Yes or
Yes.
no? Microvascular surgery often associated with plastic surgery or neurosurgery?
And plastic surgery.
Is the Bankart repair a surgical procedure commonly performed in orthopedic surgery? Yes or no?
Yes.
Is a mastectomy a procedure primarily associated with plastic surgery?
Yes.
Is nipple sparing mastectomy a surgical option for breast cancer treatment?
Time's up.
Yes.
We won't be counting that last question.
All right.
We'll be announcing the winner soon. Thank you for your patience and thank you for your participation. Just give us 2 minutes. Assalamu alaikum, everyone. So we will be announcing the winner of the quiz at the closing ceremony, which is up next. Nida will now just give the closing remarks. Thank you for your patience. Thank you for participating. So I'm announcing again that the winner will be announced at the closing ceremony, which is up next. Thank you.
All right, it was very interesting and enjoyable. I hope everyone learned something new here. Thank you so much for joining us. Thank you for being here. I hope we see you next time as well. Heading over to the closing ceremony. Don't miss it, guys. We'll announce the winners for all the sessions, for the poster competitions, for the oral competition, and as well uh, the the quiz session. Thank you.
Everyone, please wait as the poster presentation session is going on at the moment. Once that session is over, the closing ceremony will begin. Thank you so much. respected guests of honor, honorable judges, and dear participants and attendees. Assalamu alaikum. Am I audible?
Yes, Haris, you're audible.
All right. Welcome to the closing ceremony of National Undergraduate Surgery Research Conference, or SurgiCon. First of all, I would like to deliver a message from Honorable Dr. Musaddiq Khan Sahab. Sir was the ex-principal of Rawalpindi Medical University. Unfortunately, he couldn't be here with us today, so he has sent a video message for all of us.
Assalamu alaikum. I thank you for giving me this opportunity to record this message for SurgiCon organized by Ravelian Student Research Society. I have spent most of my professional life in Rawalpindi Medical College. Anything that is associated with Rawalpindi Medical College is very dear to me, especially if it is related to surgery, as surgery is my life passion. When I heard that you have organized an activity under the banner of Rawalpindi Medical College and surgery, I was very pleased. On top of it, when I was told that you have added the flavor of research to it, and that too by medical students, I was literally swept off my feet. I wish I could have been there with you to participate in all the activities that are taking place. Research is an integral part of learning. Ability to question, ability to find new solutions or new ways to solve a problem, and even to find or to look at a problem with a new perspective is something that agitates one's mind and forces one to think. And this is how new knowledge is created. We need to develop this ability in our young undergraduates. I, as the principal of Rawalpindi Medical College, had organized research workshops for medical students in collaboration with British Council. Today, looking at all the research activities that are blooming in Rawalpindi Medical College makes me very happy and very proud. I hope this platform will become a major takeoff point for research activities in all of the countries. I wish you best of luck. Thank you very much.
Thank you so much, sir. Now we are delighted to introduce Ms. Fatma Faraz, final year MBBS student and president of Rawalpindi Student Research Society. Fatma's passion for research has translated into a vibrant research community among the students of Rawalpindi Medical University. As the president of Rawalpindi Student Research Society, her initiatives continue to provide a platform for students to develop and showcase their research skills. Under her guidance, RSRS is successfully nurturing a research-oriented environment and facilitating opportunities for the intellectual growth. I would like to invite Ms. Fatima to deliver the closing note for the SurgiCon 23.
Assalamu alaikum, Haris. Can you hear me?
Yes, I can hear you.
Hello and assalamu alaikum, everyone. Together, as we gather here at the closing ceremony of SurgiCon 23, an event that has been brought together by some of the brightest minds of Rawalpindi Medical University. Truly, it has been an honor for me to serve as the president of RSRS and witness the remarkable progress that we have made together. Throughout this conference, we have witnessed groundbreaking presentations, thought-provoking discussions, and collaborative exchange of ideas. I would like to express my deepest appreciation to our esteemed keynote speakers and panelists for their illuminating talks and contributions. Also, I would like to extend my heartfelt gratitude to all the students who have shared their valuable insights and research findings. All of your presentations were excellent, And for me, all of you are the winners today. Keep up the good work, everyone. And last but not the least, I must acknowledge the hard work and commitment of our organizing committee from RSRS and Surgical Interest Group RMU, and of course our patrons, Vice Chancellor RMU, Dr. Jahangir Sarwar Khan, Dr. Arshad Sabir, Dr. Afifa Kulsoom, and Dr. Junaid Khan, who have played an indispensable role in making this conference a resounding success. And thanks to our judges for their valuable time and for thoroughly evaluating all the posters. I know you all are eager for the results, but before we proceed, I kindly request your patience for just a couple of minutes. I would like to share some exciting news for you about our future initiatives and research programs that are planned exclusively for you. I'm going to share my screen. Haris, let me know if it is visible.
Yes, it's visible now.
All right. Just a second. And can you see my screen now? Haris, can you see my screen now?
Yes, I can still see your screen, but it's blank at the moment.
There is your screen sharing is paused, but I don't know. Just a second. Can you see the slides now?
Yes, Fatma, sides are visible.
Right. So starting off with just a glimpse of what we have achieved in the past 10 years. Kudos to everyone for being a part of our team. These are some of the future initiatives that we have planned for you. Just a brief introduction of the research training program. This is going to be a series of on-campus interactive research workshops covering the 6 critical steps of an online research, from topic selection to journal selection, with each workshop comprising of a didactic lecture followed by a hands-on practice session. These are the components, and it's going to take place on 12th to 17th June at Old Teaching Block RMU, and from 19th to 24th June at New Teaching Block RMU. Best of all of these sessions are going to be completely free of cost. Next, we have systematic reviews and meta-analysis course. It is a virtual course designed for undergrad medical students, providing them with the essential skills to conduct high-quality systematic reviews and meta-analysis, and of course, publish them in high-impact factor journals. And these are the components. It's going to take place in June 2023, and it's going to be a virtual series. Next, we have national quiz competition, which is specifically for undergrad medical students, and it's a quiz on research and publication. It's going to take place in August. Medical students from all over Pakistan will engage in a thrilling online quiz tackling questions that span various research methodologies, evidence-based medicine, publication ethics, and current advancements in the medical field. I invite all of you to take part in this quiz. Prizes will be awarded to the top performing teams or individuals. Thank you so much. And I now invite over to you, Haris. You can invite Hamza.
Thank you so much. Thank you so much, Ms. Fatma. Now we are delighted to introduce Professor Dr. Arshad Sabir, Dean of Department of Community Medicine and Patron in Charge of Ravalian Student Research Society, With his distinguished career in the field of community medicine, Dr. Arshad brings with him a wealth of knowledge and expertise. Under his guidance, RSRS has flourished as a platform for young researchers to showcase their work, engage in intellectual discussions, and contribute to the medical researches. Sir, over to you, sir.
Thank you, Haris. And Assalamu alaikum to everybody. Bismillahirrahmanirrahim. Actually, this research conference is an outcome of the efforts that have been initiated after the inception of this medical college in the form of Rawalpindi Medical University, and which worked under the vision of the Vice Chancellor and under the concept of his motto of the university that was constructed keeping in mind the wisdom, truth, and the service. So we know that this is the truth component, truth part of our motto, that how we name the university, which is the house of knowledge in the city, which is one of the public sector university that was a newly established university. It was dreamed at that time that how we can make this university research intense. This conference or the platform of the RSRS is one of the outcome of that effort that have been initiated 3 years back. So every one of you is well aware of the importance of the research in any scientific field, because medical field is such a field which has done most of the research in the world. And you know that the research is basically needed to improve the scientific body of knowledge in any relevant specialty in which you are working. So I specifically congratulate to the team of RSRS, which has done a wonderful job, and these people are doing this great job since last about 5 years. And this is this year they have done this. Every year they added something new, and I am specifically thankful to the people all over the world which have some connection with the Pakistan, and they have shared their real life experiences, which has made it is possible for the upcoming medical professionals that how they can perceive their needs, future needs in terms of research and academic development. Because we know that we need the research not only to make up, to build up the scientific body of knowledge in the relevant fields, because we have problems in a country like Pakistan. We not only have the problem in the biomedical field, but we have the social and behavioral problems towards the medical care as well. And we know that the research is our scientific inquiry is the only solution to any sort of problems. And when my students, I mean the students not only who have joined this conference, but I mean the whole medical student community, these are the potential scientists, potential research scientists of the future. I hope that this conference they're learning the process and the business of this conference have definitely added to their knowledge, and they have made something clear down, not only in the form of the research methodology, but actually how they can think about their future settings in the form of research as a career or as a part of their professional work settings. With this, I am grateful to the team of RSRS, those people who have done this wonderful job. And specifically, we must be always thankful to the Vice Chancellor, Professor Muhammad Umar, because what today is happening, the central man, the man behind all this thing is the Professor Muhammad Umar, who want to make this research, this university is research intense, and through this work, our actual purpose is how we can improve the health of the human beings, and how we can we can share in research market of technology and the innovations, which is definitely based on the research work. So with this, I am thankful again, specifically to the contributor of this conference all over the world. Those people have done a great job. Inshallah, Allah is because they are playing role in the development of the medical profession in their country. Thank you very much, and Allah Hafiz.
Thank you so much, Dr. Arshad Sabit, for these wonderful remarks. Now, I would like to invite Mr. Hamza Khan for the Vice President of Ravelian Student Research Society, as well as the Chief Organizer of SurgiCon, to come and announce the results. Over to you, Hamza Bhai.
Alaikum everyone. I think we will now be starting the results. Before I start, I just wanted to first of all extend my gratitude towards all of the guests that we had during our two-day conference. I would like to thank our esteemed speakers, our judges, all of the participants and attendees who took part, and last but not least, the organizing team from both RSRS and SIG that participated, and due to their efforts, this conference was a success. So I would like to first of all thank everyone, and I think we've kept everyone waiting long enough, so I think we'll begin with the results. So now presenting the results first off for the oral presentations. We have in first place, winner of the oral presentation competition is Bilal Sadiq. Bilal presented his paper on Ripasa versus Alvadro score in the assessment of acute appendicitis, a prospective study. So congratulations to you, Bilal. Moving forward, we'll now announce the runner-up of the oral presentations. The runner-up of the oral presentation is Taimun Rashid. Taimun presented his paper on Apache scoring as an indicator of mortality rate in ICU patients. Congratulations to you, Taimun. So now we'll move towards our winner of the poster competition. For the poster competition, the winner is Hafsa Amir. Hafsa presented her paper on association of photophobia with eye color, migraine, and screen time, a cross-sectional study. Congratulations, Hafsa. Moving forward now, we have the runner-up of the poster competition, which is Faizan Shahzad. Faizan presented his poster on the identification of risk factors for late onset sepsis in post-operative neonates. So congratulations, Faizan, as well. After this, we will have our winner for the case reports presentation. So the winner for the case reports presentation is Binish Sabir. Binish presented her paper on the two-stage debulking for severe lower limb lymphedema case report. So congratulations to you, Binish. Moving forward, the runner-up for the case report presentation is Saida Wili Zahra for her paper on external jugular vein angioma, a case report. So with that, we come to the end of the presentations for the oral, poster, and case report presentations. Now we will be moving towards the results of the surgical quiz, for which I would like to invite Aisha Mohammed to kindly join us on stage and kindly present the results. Aisha, over to you.
Assalamu alaikum. So I'm Aisha Mohammed. I'm General Secretary for the Surgery Interest Group RMU. So for the top 3 teams in the surgical quiz, we had Team 3, Team 5, and Team 7. Team 3, unfortunately, since Mariam Zafar could not be joined by her other team members, we have included only her name. Team 5 was Manal Zaman, who was the team lead. And in Team 7, Ahmed Aziz was the team lead. All the teams participated very valiantly. They were, their skills, their knowledge was excellent. However, there has to be a winner. So the winner for the surgery quiz was Team 7. Ahmed Aziz, Sahab Noor, and Alishba Shahid from Rawalpindi Medical University. Congratulations, and thank you so much for participating. Before we move on, I'd just like to take a moment and let everyone know of the things that SIG, Surgery Interest Group, has planned. So for now, we had Surgicon in collaboration with RSRS. They were wonderful collaborators. Since they were already equipped in taking care of such virtual conferences, it was very easy and everything was flowing very smoothly. So I'd like to thank Abad Bhai and Fatma Api, the presidents of RSIS, for their collaborative efforts, and also Hamza Bhai for being the chief organizer, as well as Usman Liaquat Bhai from SIG, who was the chief organizer from our side. I'd like to thank the panelists, the judges, the speakers, obviously, but I'd especially like to thank the participants of this quiz for their patience, for their participation. And for future endeavors, we have planned a surgical Olympiad, which will be an on-campus competition, inshallah. We will announce the dates as soon as we're done with Surgicon and as soon as Sports Week for RMU is over. But for now, Surgical Olympiad and many more conferences, inshallah, and lab and new assembly sessions and surgical specialty sessions have been planned. So thank you so much to RSIS. Thank you so much to Dr. Arshad. Thank you so much to Dr. J.S.K. Jahangir Sarwar Khan, our patron in charge. And thank you to our worthy Vice Chancellor, obviously, for allowing us to do this and for always pursuing and supporting this passion of ours. Thank you.
Thank you, Aisha. And with that, we are going to wrap up our Surgicon 2023. Once again, thank you everyone for joining, and kindly stay tuned for future activities. Thank you, everyone.